Good morning. Board members, as you join, feel free to come on camera if you are able. And as we've ticked over to 9:35, I'll go ahead and open this meeting. Good morning. My name is Dawn Mautner. She, her, and Aya are my pronouns. I serve as your chairperson for the Public Employees Benefit Board, and I welcome you to our July meeting. We have a packed agenda, as always. I'll go ahead and call this meeting to order and take roll to see if we've got representation here from the whole board. Siobhan Martin, are you with us this morning?
Yes, I'm here. Good morning.
Good morning, Siobhan. Greg Clauser, are you with us? Not hearing from Greg yet. We'll give him a minute. Cheeky Flowers, are you with us this morning?
Don Chicky will be about 45 minutes late.
Thanks, Ali. And I see a note from Greg that audio is not working, but he was here and will return, okay? Andy Fultz, good morning.
Good morning, I'm here.
Thanks for joining. Kimberly Hendricks, are you with us this morning?
And Kimberly is out of town as well.
Okay. Sean Parkman, are you with us?
Yes, good morning.
Good morning, Sean. Emily Wong, are you with us?
Yes, I'm here. Good morning.
Good morning, Emily. Rep Nose, do we have you with us this morning? Not hearing Rep Nose with us.
Here. I'm here now.
There you are.
I had to update my password.
Technology is working with us some days better than others.
Well,
good morning.
I mean,
Thanks for joining.
Yep. And it's not password for any of you that are wondering. I chose a different name.
Okay. Greg, are you with us? Not hearing that Greg has returned, but I think that is 1, 2, 5. That's quorum, and we can go ahead and get started. I'd like to acknowledge the turbulence of the environment in the setting of federal activity around funding streams for many of our agencies, including at the state level. And I'd like to acknowledge the public service that public employees provide and its value to the people and the communities of our state. Thank you for doing the work that you do. We are here to support the employees of the state and demonstrate the value that we believe that your work is in the form of a benefit package that is worthy of you and the work that you do. So thank you for the work you do. And I welcome a look at the minutes from the last meeting. Board members, have you had a chance to review?
Well, this is Siobhan. I have had a chance to review the minutes. Rose is going to fix a typo for us on page 3. That was a little confusing to make it clear that the OUS plans are 3% plans. And with that correction, I would make a motion that we approve the minutes.
This is Andy, I'll second.
Thank you, Siobhan. Thank you, Andy. All in favor, say aye.
Hi.
Aye.
Any opposed? Any abstentions? Hearing none, the minutes are approved. The next item on the agenda, thank you, board. The next item on the agenda is an acknowledgement of some concerns that have come in through the Providence Plan about a vendor they have contracted. And Ali, I think I'll hand it over to you to take this one, please.
Yeah, thanks, Dawn. Continuing on the message you opened the meeting with, there's a really good article that highlights PEB's work on hospital cap payments, PEB and OEB. Please take a look today. It's on Oregon.live. So late last week, I sent the board an email outlining a situation where some confusion. The PEB Providence Health Plan members were contacting our staff and even some of you stating that they've been contacted by their alternative care providers and told they were planning to leave the PHP network due to administrative burden and decreased reimbursement. And this is under PHP's upcoming network move to American Specialty Health. So you may have seen in your board packet an example from a member who submitted public comment. And as I stated in my email, this network change does not impact PEB's self-insured plans with PHP, but providers are not hearing the message. So with the confusion and uncertainty among our members and providers, we thought it would be good to have PHP come in and address the situation with you, what they're doing to clear up the confusion and answer any questions you might have. And staff is going to be sending out a communication as well to our enrolled PHP members. So with that, we have Cash or Cyan.
Yeah. Hi, like Ali, this is Cash. I'm here.
Hey, Cash, go ahead and take over.
Okay, good morning. Thank you so much. And thank you, Chair Modner. Thank you, Ali and staff and the board for giving us the opportunity to address some of the concerns, as Ali alluded to here just a moment ago. For those of you who may not know me, my name is Cash Spencer. I am the Senior Director of our self-funded line of business within Providence Health Plan. And for the past 15 years, I have had the pleasure of being the responsible and accountable party, managing the relationship between Providence and PEB. As Ali said, there was some confusion based on some communications and some changes that Providence Health Plan is making for its commercial fully insured plans that do not apply to its self-funded line of business and thereby does not apply to PEB or PEB members. To lend a little bit of clarity to that, and I'll make a couple more comments, but just wanted to also introduce one of my colleagues, Val Tan, who's the director of our commercial products, who will also lend some additional comments just on what we're doing with ASH and how we're managing that communication. Specifically for PEB, again, because my responsibility is the relationship between PHP and PEB, I wanted to address a couple of things that Ali did mention. First, this communication and the changes that are being made are for the self-funded or for the fully insured line of business that's happening starting September 1, and it does not impact PEB at all. We are not making any changes to PEB's benefits. We're not making any changes to PEB's plans. PEB's plans are self-funded. So this board, the PEB board, makes all decisions for PEB's benefits. PHP does not make those changes. We are working very closely with our product teams, with our marketing teams, with our communications teams to try to clear up any confusion and also understand the impacts that this could or potentially have on the accessibility and the availability of providers in PEB's network. At this time, we've been informed that we're confident that the network will still be relatively stable for PEB members, but we're working to continue to validate that. At this point, we are not making any changes to anything that impacts PEB benefits. So I just want to restate that and re-say that. With that, I'm going to turn it over to Val to provide some additional comments just on what we're doing for with the commercial plans. And
Absolutely.
Ash.
Thanks, Cash. Hi, everyone. Thanks for having me. I just have a few items to share with you this morning. To reiterate what Cash said, PEBB is out of scope for the PHP business decision to move administration of alternative care benefits for our fully insured plans to American Specialty Health, also known as ASH. On September 1st, providers will continue to be reimbursed by PHP at the current rate for self-funded groups, including PEBB. PHP is working very closely with ASH as our delegated vendor to mitigate any provider abrasion through additional notifications and additional provider education. This includes updates to language on the ASH Link provider portal, targeted emails to providers who've reached out with questions or concerns. And PHP has also provided ASH with a list of all self-funded groups that are not impacted by this change so that that can be included in future provider communications. PHP has utilized the ASH network for more than 25 years, and other carriers have chosen to use ASH in Oregon as well. ASH does bring a strong national network of quality providers that are monitored closely to ensure that they practice evidence-based medicine. So at a high level, that's what I wanted to make sure you were all aware of. Happy to answer questions if you have them.
Siobhan.
I see Siobhan. You have your hand up, Vice Chair.
I do, thanks. I think Cash, you're aware I've been contacted both by our members as well as folks who are concerned about this change that aren't our members too, have been reaching out.
Sure.
So what I'm curious about both, I've heard both about the fully funded folks having their amount cut for their benefits. The reimbursement rate will be lower, and there will be hoops that folks have to get pre-authorizations. I know this doesn't impact PEBB. My understanding is the pre-authorizations and the lower reimbursements impact the fully insured book of business. And what I'm curious about is, can we be updated on providers that are actually leaving the network? Because that's what we've been hearing from folks. They've gotten very specific letters from people saying, yes, we're planning to leave the network. So, follow up if they're better educated, will they not leave the network? And then additionally, Cash, I appreciate that you shared some information with the leadership here, with myself, with Dawn, with staff on how you're responding, the correspondence with providers. I just want to make a comment that I would just urge you, because these are folks who don't necessarily have administrative help, that go through lots of conversations with the healthcare book of business. And so I think there's probably lots of misunderstanding about what terms are, and are they fully understanding what the impact will be to their own businesses?
Yeah, and we've been working on that. Thank you, Siobhan. We've been working on that with ASH, with our leadership, with our communications team internally, our provider network team internally, just to work through all of those points that you just made. We're also working on re-educating, as Val mentioned, re-educating providers, ensuring that they understand what this means, but also what it doesn't mean. We believe there's confusion on even some of the things that we've seen in some of the correspondence that have gone out to our members or your constituents, that may not actually be accurate as far as what the requirements will be under this new delegated arrangement. So we're also working through clearing up the misinterpretation, the confusion around what those terms mean as far as utilization management. I won't profess to be an ASH expert, although I've kind of grown my expertise just in researching a lot of the concerns that PEBB members and other self-funded members have expressed. What we found is that there are a significant number of patients that are receiving care that never require, because of ASH's model, that there's certain providers that never ever need to submit any type of utilization or prior authorization documentation, but they've interpreted that to mean that we will be requiring it in 100% of the cases. And so some of that is also part of the confusion. So we're doing, they are doing educational opportunities, educational models, additional communications and correspondence. As Val mentioned, I provided ASH with a list of all of our self-funded customers, including PEBB, so that providers will know who's out of scope. So that way they're not assuming that the entire Providence Health Plan book of business is included in this. So we're working on a number of fronts, taking a number of different ways to try to clear up that confusion.
Appreciate that. Thank you.
Oh, one thing that I will say, Siobhan, you asked about network access. I can promise you that is one thing that I am monitoring, and I've asked on multiple occasions that we continue to monitor as we've seen some of the threats that have come from some of the providers to drop from the network. There have been occasions where we've seen it's been like several cases of one provider or several patients of one provider receiving the same correspondence. So I haven't quite yet seen a large number of different providers, but it's been like multiple patients of one provider that has expressed that they're going to leave the network. But we haven't yet seen where any have done that yet. So we are monitoring that because my commitment to PEBB and our commitment to PEBB is to ensure that you have an adequate network that members have access no matter where they are across the country.
Thanks. And that's something you can provide to PEB staff if folks are dropping.
Absolutely.
We can get that information from ASH if we need to. And those where we have seen that multiple communications from one provider, that's where that targeted outreach has happened to try to clear up any misinterpretations there. And then we're also working very closely with our communications team and the ASH communications team to just make sure everything is very consistent as it goes out and everyone's getting the same message. I think Greg may have a question.
Maybe a question comment. Can you hear me
Sure.
okay? I have
Yes.
a lot of problems getting on today. So if I understand correctly, of course, ours is not changing, but maybe some of the individuals or an individual or two that are looking at dropping, it's because they have more or other patients from the other side. And they're maybe going to lose some funding or some money coming in from that side, not from our members. Am I getting that correctly?
That is a potential possibility, but I will say that the self-funded membership is much larger than the fully insured membership.
That's kind of what I thought. Yeah.
Yes.
And so I guess maybe just some of is if we do have, we're looking to see who does drop. My thought process is for our members, the letter we received and what we're probably going to find out is that because, and this is just me throwing it out, because PEBB did this, my person is now no longer going to cover me. I think what we need to do in that messaging is make sure that we let them know that it's not because of the PEBB member. It's the individual themselves and maybe another company or, the other side. That's the reason that their provider may no longer be in. It's not our fault as PEBB. Does that make sense?
Yeah, it does. And we can certainly work with you, PEBB staff. I know Ali mentioned that there was going to be some communications going out. We can certainly help with that. We were exploring potentially sending out something similar, Greg, just to our members to inform them of that
We're still
doing
the same. We're still paying the same. We're still giving that doctor the same. It's not us. It's the doctor deciding that maybe they're losing a few dollars on that other end that they may not want to now be with that plan. It's not because of the PEBB plan, us as not just us as the board, but our plan as a whole is not doing this to them, which a lot of times I think what individuals feel is that the PEBB board has voted for these things to happen. And we need to make sure that we show that, number one, we here really do, because some of us are on the PEBB plan. We try to make sure that it's the best that we can get for everyone. So that's just my 2 cents. So thank you.
There.
Thanks, Greg. I think it's worth acknowledging that the complexity of the payer picture that providers have to keep track of is worthy of note. That the fact is that it's not even multiple payers in this case, but multiple plans within a payer, and the potential for confusion about a payer with multiple plans making a change that impacts a subset of the patients who get care at a particular provider, but that subset decision impacting the provider and the clinical setting enough that they may make a decision to no longer participate and withdraw from working with that payer. There's a lot of complexity there for providers to have to navigate real understanding of how the payer systems work, especially for those providers who work in smaller settings and don't have a whole billing department that's going to take care of all that. If you have a small solo provider or only a couple of providers working in a clinic out in rural Oregon, it may be on them to understand, and they may not have taken the time or had the time to work through all the communications to be able to understand the distinction. And I want to acknowledge that sort of administrative complexity that the providers have to navigate. And I do appreciate the attention to supporting that communication on the part of Providence to ensure that the providers know that their PEB-related clients are still supported as well as PEB clients can be supported. And maybe that'll make an impact and keep some folks in the network and keep the network strong for our PEB members. Are there any more questions or comments for our Providence colleagues here? Hearing none. Ali, was there any wrap up you wanted to do there?
No, just thanks for coming to the meeting and talking through this. It's really important, and I'm really glad that you came in. Thank you.
Thanks for having us.
Thanks for coming. Then we will go ahead and move on, and I will hand it over to Ruby Castaneda and Brian Olson, I believe, to discuss the RFP. If I'm not mistaken, there's an action associated with this part of the agenda. Ruby and Brian, are you here?
Yes, I am here. Hello, board members. My name is Ruby Castañeda, and I am the lead PEB member for this RFP project. Just waiting for some slides to come up. Thank you, Maggie.
Sorry about my pronunciation, Ruby. I'll get that better next time. Ruby Castañeda.
Yeah, thank you. If you could please move to the next slide, please, Maggie, that'd be great. So just some reminders for potential proposers that are out there. Please do not make comments or questions for this presentation, as we have a lot of information to provide our board, so that way they can make a good decision in terms of the release of the RFP. Thank you for your cooperation and understanding, because this is a very high profile RFP, and we want to make sure we do our due diligence in ensuring the integrity of the RFP process in itself. Next slide, please. So today's objectives, we want to provide an overview of the RFP development, timeline, and rules. We want to highlight some content of the medical and pharmacy questionnaire and present the structure and design, including the processes for selecting finalists and winners. And then we're going to ask for the board of the release of the RFP. Next slide, please. One more. So as the board is well aware, we started this project in 2023 when the board made the decision to go ahead and do an RFP for the medical and pharmacy aspect. And as you can see, there's been quite a few milestones of this project. And we got a lot of the information during the 2024 board retreat that helped us design and develop this RFP. In looking into the future, if you see the highlighted pink box for Q4 of this year and leading into Q5 of 2026, we are hopeful that we will have some finalist selections and apparent successful proposers. Next slide, please, Maggie. And so here are some of the roles that we have. So the core project team, which consists of PEBB staff as well as the Mercer team, who I can't thank enough for helping with this process. It was a huge undertaking and lift, and we are hopeful and that we have been able to accomplish the PEBB board's vision of this RFP. The drafting team will consist of PEBB staff and consultants, Mercer consultants as well. We have two sections of groups. So one of the sections is the advisory group that will consist of some of PEBB board members as well as additional staff members to ensure that we have everything that we need, policy changes and decisions that we would want to present in the future for the board to make a decision on. And then we have our evaluators and scorers. Currently, we only have 2 board members, which is Sean Parkman and Greg Klauser. There is opportunity for 1 additional board member if they would like to be an evaluator. We welcome that. And then the decision makers, which is the entire board. And we're looking forward to be able to come to a great selection of proposals that the board will be able to make a decision on. Next slide, please, Maggie. And 1 more, please. I think Mercer was going to take this, if I'm not mistaken.
Hi, Ruby. Yeah, I can take it. This is
Thank you,
Hoffer,
Andrew.
Mercer. Yep, yeah, no problem. All right. Hi, everyone. Good morning. So in this portion, as we sort of move forward through this content, we're going to start with talking about the RFP development process and some of the key components. And so we're going to start high level, and we're going to get a little bit more specific as we go through some of the following sections in this presentation. And so, obviously, one of the key purposes of this RFP is to see what's available from the market, from health insurance providers and payers, from PBMs, with regards to these areas that are of highest priority to PEBB. And so starting at the top with the 3.4% limitation on annual cost growth, obviously benefit coverage and costs are important related to this RFP, but there's other components as well, which we've included in this RFP flower, I guess I'll refer to it as, around improved member experience, driving to higher carrier accountability, centering the structure and delivery of the care within equity, behavioral health, both from an access perspective as well as high quality care. Another key components around care and case management, and so ensuring that PEBB's sickest and most complex members are getting really high touch support, including integrated behavioral health support as needed, and alignment with key Oregon needs. And so an example of this would be, ensuring that there's adequate provider access in rural parts of the state. And so our process, going back to late 2023 during the retreat that happened then, was to first identify what are these key components and start to develop PEBB's point of view around priorities and values within each of these key components. And so to do that, we had these monthly discussions, which Ruby went through on that timeline slide, where we would choose individual topics, whether it's pharmacy or care management, and have a robust discussion with the board to understand, again, your values and your priorities within each of those sort of distinct service areas. After those meetings, collectively, we worked on position statements. And those position statements really informed the questionnaire development, which we're going to get into in this presentation. And so another key part of, or another key source that influenced the questionnaire development was around the triple aim of member experience, lower cost, and high quality care. But it actually was a little bit broader than that. It was really more like the quintuple aim, so incorporating provider well-being and equity. And so, we all know that equity is sort of the foundation of PEB's strategy, but provider well-being is important as well. It's not something that we talk about quite as often, but it is really key to ensure that those providers are not burnt out, they're being adequately compensated. And it's sort of recognition of the idea that if they're not at their best, they're not going to be able to serve the PEB population to the best of their abilities. And so if we want to jump to the next slide, and I'll try to keep an eye out for hands, but please just jump in if anyone has a question or comment that they'd like to pose, and I'll do my best to keep an eye. Another key part of the development of the RFP was around this member survey. And so at the board's request, we did conduct a member survey in early 2025. And the intent here is to really hear directly from members what are their concerns around medical and pharmacy programs and related to this RFP specifically. And so this slide attempts to summarize some of the most relevant findings. And the first of which I'll call out is that there were really two primary concerns that bubbled to the top. One was around affordability, and the other was around access to care. And so a couple of data points that support those findings. On the left side there, you can see that 64% of members who responded noted that they did have difficulty finding providers with available appointments. 43% of respondents did say that healthcare is too expensive. And so as we move into the right, we've got a couple of more specific data points that really speak to these primary concerns of affordability and access. And so starting at the top, 39% of those who responded to the survey said that they had a preference for raising out-of-pocket expenses for covered services to achieve, the cost sustainability that's required to limit cost growth to 3.4%. And so for those, we'll call it 40% of respondents, they would prefer out-of-pocket expenses to go up as opposed to contributions through their paycheck. 36% of respondents did say that they would be willing to consider a more limited network of providers as a means to sort of driving towards that sustainability from a cost perspective and achieving 3.4%. In the middle of this white section on the slide is really more about access and some of our data points that we found from this member survey. So about 3/4 of members said that one of their primary access concerns related to this RFP was around the potential to find a new primary care provider. That finding makes a lot of sense to me. These are often relationships that are longstanding between the member and the PCP. That's a relationship that's built on trust, and so it's not one that's easy to replace. And so to see that high level of concern is understandable. We found a similar finding, but a little bit less concern as it relates to specialists. So 55% of respondents said they would have concerns around finding new in-network specialists. And likewise for pharmacy, 31% of members who responded said they're worried about changing their pharmacy. So in the bottom right, we've got a couple of specific pharmacy findings which we wanted to call out. These respondents, as it relates to pharmacy specifically, they actually would prefer to pay less out of pocket for their prescriptions as a way to drive to cost sustainability. And that's another one that I think makes sense. For a lot of members who are taking medications, a lot of those medications are ongoing. And so they're going to the pharmacy, every month, or they're getting their 3-month supply throughout the year, sometimes indefinitely. And so there's a lot of opportunity for out-of-pocket costs when you're seeing the pharmacist every month. And so it makes sense that would be a primary concern to those members. About 50% of members who responded did say they are willing to pay slightly more if that means access and coverage to some of the newer medications that are hitting the market. However, 43% that they are not willing to spend more to get access to the sort of newest medications that are hitting the market. And so this was, I would call this effort pretty successful. We had a great turnout with this survey, and it helped inform some changes that we made to the RFP, both related to the scoring and how those different sections are weighted, as well as some adjustments to the questionnaire. So with that said, I'll pause. I see Andy, you have your hand up. Go ahead.
Oh, I just wanted to know what percentage of PEB members responded or what the number was compared to the overall number of PEB members.
So team, keep me honest, I think we had 5,000 respondents to this survey. I'll just look and see if anyone can validate that or correct me either in the chat or.
You're right, Andrew.
At 5,000, okay.
Yep.
All right, thanks, Maggie.
Oh, so what percentage of that is, my math is horrible, is that of our members?
Emery, you call it
Yeah,
150,000
it's
members?
well, it went, I think, only to employees. So there's about 60,000 employees. So it's about 8%.
Great, thank you.
Thanks, Emery. Yeah, great question. Okay, so if no further questions, I'm going to pass it off to Emery, who's going to start to talk about the medical questionnaire and give you some examples of some of the different types of questions that we'll plan on posing to the bidders.
Thank you, Andrew. So the next couple of slides, plus I think the next couple of sections, really talk about the guts of the RFP in terms of the questionnaire and the types of questions and types of information that we are providing or asking of the plans potential bidders to provide. So I think some of this information you may have seen before. It's very similar to some of the information we had kind of brought forth to the board during the retreat, but the RFP, in terms of the questions that we're asking, they're going to be essentially covering these topics. So member experience, clinical services, the network access, data reporting, services and admin, and the financials. So all of these sections, there are going to be lots and lots of questions regarding the capabilities around these areas and essentially the ethos of the bidders to providing these services to PEB. There are subsections in each of them, so you can see down below, with behavioral health and health equity that actually, goes throughout many of these sections. So there are multiple questions about those in every section. Member experience with advocacy and navigation, that's going to be another key part of it. Clinical services, talking about the integration and also how, they manage physical health in this case. Network and access, that's definitely very important to PEB. As Andrew mentioned from the slide on the poll, it's very important to the members. And then so some of the others on the right are a little bit more behind the scenes. The data and reporting, what can be provided there, just ensuring that the services admin are there in terms of just being able to provide and implement and to make a plan run well, and also managing the security and privacy on those lines. So in the far right section, the financials, with the 3.4%, obviously that's a huge part of this. This is one of the things that we're going to be focusing on. We do have the potential scoring a little bit later, so you can see the weight that's applied to each of these sections. But with the financials, it's not just the cost of providing services or the contracting, but performance guarantees as well, because ensuring that these plans are willing to actually stand behind what they say they can do. So that's going to be a big part of it, and as well as for the advocacy. PEB has put in Garner for next year, but in terms of the advocacy, return investment, and just managing the trends, that's something we're going to be asking as well, and asking the bidders to prove that they are actually capable of doing these things and providing essentially a lower trend for PEB. So there don't have to be cuts made for benefits in this case. That line below, the bidder, in order to have the bidders understand exactly what PEB is looking for, there are some position statements that are created that have been drafted to highlight PEB's values. We will go over some of the higher points of those position statements, but they are on each of these major topics and also include health equity. And so you can see that in some of the upcoming slides to kind of hopefully I guess, make sure that, those statements are capturing what the PEB board has wanted and what we heard from the PEB board in terms of what kind of medical plan that you want for the future. Any questions before we move on to the pharmacy portion of the questionnaire? Okay. Sarah, I believe you're on.
Yep. Thanks, Emery. So this slide is similar to the previous slide that you've seen, only it focuses on some of the areas that we're asking about related to pharmacy. And you'll see there's more bullets on here, and we all want to think pharmacy is easier, but sometimes it doesn't feel that way. It can be more complicated. And so we're really focusing our questionnaire to make sure that we're getting into the nuances of some of the different offers from the PBMs and really being able to capture what those differences might mean for PEB and for PEB's members. So there's the pricing offers and the financials, and we would do a detailed modeling of each of the offers. We're requesting transparent pass-through pricing, so there wouldn't be any PBM spread. We'll be evaluating discount and rebate guarantees, as well as what's included and what's excluded in the guarantee. Sometimes just looking at the guarantee doesn't give you enough information because it all depends on what's included in that guarantee. We're looking at the definitions and how the PBM defines something like a generic drug or a brand drug. And then also we want to make sure that PEB has the rights to a market check, meaning that you can check that pricing and renegotiate it every year or on a periodic basis to ensure that your pricing continues to be competitive in the market. We heard from the member survey that access to pharmacies are important and people are concerned about changing their pharmacy. So we're going to be looking at retail networks, how the networks are maintained, what kind of notification PEB would get from pharmacies coming out of the network, and then stability of the pharmacy network over time. Also looking at formularies, and we know that formulary disruption could be concerning for PEB members. So we'll be doing a disruption analysis to identify how many members and which prescriptions could be disrupted for each bidder. But then also wanting to understand how the PBM would manage that disruption, what kind of communication happens to the member. Clinical capabilities. So some of these we've talked about in PEB meetings in the past, looking at what is the PBM able to do for fraud, waste, and abuse. What kind of clinical programs do they have? Specifically, we'll be looking at things like opioid management. That was a suggestion from one of the PEB members. Looking at what's available for specialty pharmacy, how the preventive list is managed, and then what kind of capability the PBM has around e-prescribing. Like Emery said previously, the pricing offer kind of goes hand in hand with performance guarantees. So we'll be looking at what are your rights to audit, what kind of guarantees is the PBM offering on a smooth implementation and member service? What's the corrective action plan process if something's found in the audit? And then also wanting to understand how much of the fees are at risk for those performance guarantees. Around service and operations, this is kind of the day-to-day of what the PBM does. What does their account management look like? What can they accommodate in terms of different plan designs? What do their member service and tools look like? Like what is their website? What is their app? All of those kind of information. What are your termination rights as a client of the PBM? What do they offer for mail service? We've even got a special question, I think, asking about different kinds of mail service providers that could be available. How do they handle compound drugs and what's their claims adjudication process? And then that last category we know is really important to PEB, and that's around transparency, reporting, and total revenue disclosure. So we are asking some questions around fiduciary responsibility, how the PBM interacts with their rebate aggregator or GPO, really wanting to understand what's that relationship and where are there opportunities for additional revenue for the PBM or their affiliated entities. We are asking for detailed rebated reporting at the drug level. so that PEB will get information on what is the net cost of the drugs, net of rebate. And we are asking each of the PBMs to participate in what we call a total revenue disclosure, where PEB can understand what are the sources of revenue for the PBM and what the magnitude of those would be. So that's a lot, but happy to take questions. I see Representative Nos, you have your hand up.
Yeah, thanks for taking my question. So are we really contemplating decoupling the pharmacy benefit from an insurance plan benefit?
So we are, as part of the RFP, we are requesting both what we call carve-in bids and carve-out bids.
Okay,
So
wow.
the way that it could, so depending on what the different combinations look like, the winning bidders could be a carve-in where you have medical and pharmacy in one entity, or it could be one entity for medical and one entity for pharmacy.
Oh, it's really interesting.
Yeah. So sorry, Rep. Nos.
Go ahead.
So
Go ahead.
it's not it's not guaranteed that it would be decoupled. We will go in a little bit more detail about this.
Yeah, I get it.
We are requesting, basically to try to get the best possible value for PEB, right? We are requesting to see what's
I'm
out
just
there,
not seeing
and
that
we will
very
compare it
often.
against every.
Yeah. Usually
Yeah. So
the medical plan sort of guards its operations around the formulary and what discounts it can get and rebates, all that stuff. And then efficacy of all those things. This is really interesting. This is why I like being on this board. Sorry to take up a little airspace here, but like it's a practical reality check for me for all the things that I legislate around, particularly around PBMs and spread and total transparent. All the things that you are talking about are things that we are constantly debating in the legislature.
yeah.
Yeah.
So I mean, if you want to, continue to learn, you could, help participate in
Now,
the
I
RFP
did,
scoring
as
process.
all of you have heard me whine many times. I did this thing 10 years ago. It was hell. And I am not doing it again, ever.
And we do thank you for your service, Rep.
Oh,
Nos.
it was such a hard RFP process.
So
I mean, it's important. I get it. All right, going back on mute.
go,
Hi,
if I may just,
I just wanted to add to Representative Nos for, what we've seen typically, the larger the employer is, the more likely almost they are to have pharmacy as a separate entity than from medical. It's more than half of larger employers do have a carve out PBM. So it's not out of the ordinary from what we see and worth considering.
thank you for that, Sarah. If I'm not mistaken, pharmacy is a massive majority of the spend. Am I correct about that? Not massive?
Not, it's a massive amount of spend. It's not a majority. It's like, depending on the plan, it can be, I think for PEB, it's about 20%.
Oh,
Or
it's
like the
that high.
statewide
I
and
would have
some,
thought it would be
yes.
15. Okay.
Yeah.
Okay,
I mean,
that's
it
useful
is,
for me.
yeah. It's just
that's not including the medical pharmacy portion, which is also a big amount. But that's actually considered as part of the medical spend. So this is just purely PBM spend.
right. I mean,
So with the medical
Dawn,
pharmacy,
you think
yeah.
about every time as a physician where you saw somebody and they're like, you're not going to give me a prescription. I'm not getting any, like, I'm not walking out of here with anything, like it was bad.
It's a good observation. So
Yeah.
medical pharmacy versus PBM pharmacy. Could you spend just a second clarifying that for me, please?
Yeah, Sarah, you want to handle this?
Sure, I can take it. So medical pharmacy tends to be those medications that are administered either in a clinic or a hospital, or sometimes it can be home infusion. In those cases, it's typical for the medication to be billed on the medical benefit rather than the point of sale pharmacy benefit. So we call those medical pharmacy drugs. Treatments for things like cancer tend to be at the top of the list of those medical pharmacy where people go to an infusion center.
And those, because those are combined with the medical spend, it's not as easy to parse.
Correct. Yeah, the medical pharmacy drugs tend to be one line in a multi-line claim for an encounter in a, say like an outpatient hospital or something like that. It can be more difficult to parse out the exact amount for that drug because it's, there's also facility fees, administration fees. It's more than just the prescription.
Got it. Thank you for
Yeah, and
helping me pull
yeah,
those apart.
yeah, and Sean, before we call on you, just it tends to be the medical pharmacy tends to be really some of those really high cost drugs that are coming out now. Uh, and one area of particular concern with PEB and OEB, but with the 200% of Medicare limitation, a lot of facilities are getting paid at 200%, and that's 200% on the medical pharmacy as well. So basically, you're taking $1 million drug and they're making another $1 million profit because they contract at 200%. And so that's one area of concern where we don't want to see PEB paying much more than they should be for these types of drugs administration. And we have noticed, I mean, there has been instances recently, and we've tried to push back, and it's like, well, this isn't a contract. And so this is something we want to focus on in RFP.
Thank you for that. Sean.
Yeah, so I think this is a question. I think my understanding is, the classic example, you have someone that goes to the emergency room, maybe they end up in the hospital for a couple nights, and they get, let's just say they get aspirin while they're in the hospital. That could be like an $80 aspirin just because it's in the just because it's in the hospital, even though chemically it's aspirin. Probably costs 20 cents. So that would go under medical rather than pharmacy because it's all under, it was in the hospital when they gave it to you. Is that correct?
Typically, if someone's actually inpatient hospital, the cost of the drug kind of gets bundled in with the whole hospital payment. But certainly for outpatient hospital, if you go to the emergency room and they give you that aspirin, that's going to be considered medical pharmacy. Because it's going to be billed on that medical claim, not an outpatient pharmacy claim.
Thank you. I have more to learn about this and look forward to learning it, but I don't need to stop us anymore, please.
Okay. Thanks. Sarah, is there anything else you wanted to add on the slide? Okay.
Nope.
So we can move on to the next section. So while we talked about the various sections, we're going to provide a little bit more detail on what's in the RFP. So this first couple slides actually have highlights of the position statements, essentially those value statements that we're going to have kind of leading off each of these sections. So for the board, I recommend just kind of reading through some of these, but this is not going to capture everything that is in the position statements, but hopefully it gives you a flavor of what we are highlighting as the key tenets for the RFP and what PEB wants. So the first 4 position statements are here. So member experience is on the top left. So some of those areas where we talked about and tried to show where to the bidders what PEB really is looking for is ways to simplify navigation access, holistic member experience with advocates to help guide through the system and their journey to make it a lot easier. There's a lot to learn in the healthcare system, and your members are not. You're not going to be healthcare experts, and they need. I mean, they need help to help guide through it. Sometimes you might have a friend. Sometimes you might have Dawn to help you guide through some of this, but it's not going to be, not everybody has that. And so hopefully the member experience, those advocates will help the member find the right care, the best care, and to help them with all those questions and like the paperwork and everything else that goes along with healthcare. So, the partner will help create a cohesive ecosystem. It's like there's many, many parts to healthcare. We want to make it simpler, make it easier to understand, easier to access, and then to actually find out those things, to know that those tools, those resources are out there. Because many times you might not know there is a tool for it, and that hopefully the partner for PEB would find and help those members get to those tools and to really make it a good experience rather than just disparate parts. And also health disparities and social determinants. I mean, everyone's different, uh, different situations in life, different diseases, different just things impacting you. And so just trying to get the partner to be able to not just support one type of, just maybe the critical care or just like a standard type of member, but to be able to address all the members and just work with the members wherever they are in terms of their healthcare journey or their situation in life. And along with that, really the health equity, it's a key part. It's the value system for PEB, just trying to create an inclusive healthcare system, recruit diverse providers, and help address health literacy, just making it equal for people or as equitable as possible. It's just addressing where there's potential deficiencies, identifying area times where there might be where the member might not know, might not have the knowledge, and just being able to identify that and then help them in this case. Um, and also using data to help take a look and see where there are issues, where there are inequities, and do interactions with that, and to try to create solutions or processes that can help. It's not. It's you find out things when you actually work with members, but try to be a little bit more proactive about it to identify where certain types of members might have certain issues or where there are people don't know that they have issues. I think that's one of the big things um, when you start taking a look at the data. It's like, oh, this, certain conditions aren't being cared for equitably across all members. And, PEB, I think health equity is a fundamental right. And so that is essentially, I don't know, the key theme kind of running through this in terms of health equity and the RFP. And down below, behavioral health there on the left, there's been a lot that PEB has worked on terms of behavioral health. There's a lot that PEB continues or needs to work on for behavioral health and wants to get that partner to believe in it, to access it, to help create that, right? Creating that diverse provider network, making sure everyone has access to care. That is, with the performance guarantees with behavioral health, we want to step beyond just that to increase it, to come up with innovative solutions and partnerships to increase the access and enhance the networks. And behavioral health, some of the audits that we've done in the past, noticing that, it's not necessarily integrated. It is a lot of times just kind of separate and handled differently from medical. And that's not the way, people are, right? Behavioral health is it's part of, it's not just behavioral health. It's part of who you are. It impacts how you are physically, how you are with your health, and it's just the correlation and it's just everything that's going together and just trying to make sure it's integrated in this case and to holistically help each member. So there on the right, talking about clinical services, I think, a lot of the things we talked about with the first three are, would play a role in the clinical services, in making sure the member has the communication and resource connection, addressing all these the right, addressing all these behavioral health, social determinants, and how that impacts the complex cases, comprehensive support, and also I think that first bullet, managing member health, and if you can manage members' health, hopefully that helps out with the trend in reducing costs in the future and helping PEB meet that 3.4% limitation. So these are 4 of the position statements. We do have 4 more on the next slide, but wanted to pause here and open it up, see if there's any comments, concerns, additions that the PEB board might want to see in some of these position statements, or at least, things that might be that you want to ask about. Go ahead, Emily.
Yeah, thank you so much for creating these position statements based upon what we've shared in previous meetings and retreat. I'm just thinking about health equity and a lot of culturally specific communities and how they're more family based and collective based than like individual based. And I know we've talked in the past, about, trying to integrate more of that kind of family based approach thinking. And so I'm just not seeing it reflected here. And so just hoping that we're still, you know, highlighting that preference for a lot of our culturally specific communities. And I just went to this Vietnamese home care worker meeting with SEIU 503, and I was amazed at like these home care workers taking care of their sons, for 15 years, or taking care of their parents, and these parents are living past 100 years old in in Oregon, and I'm just like, are we keeping track of this? Like these positive things that are happening. I think some of us have heard about blue zones. Um, we might even have some blue zones going on in some of our culturally specific communities in Oregon. I couldn't believe how many people were living past 100 in the Vietnamese community in Portland area because of family, like taking a family approach. And then social determinants of health. I just wanted to name that. I think that's going to be a bigger challenge than we've anticipated with all the federal cuts and cuts to food stamps and SNAP and cuts to transportation, possibly, and so, I think we know when you're having a heart attack or a stroke, every minute counts. And so, especially in those rural areas, and, if our potholes are not getting fixed, it's such a painful ride for a patient, in the ambulance, getting to their medical appointments, you know, getting to specialty appointments, and oh my gosh, they missed that specialty appointment that they've waited for months to get because of a transportation challenge, and then having to reschedule and wait another 6 months, until they get there. So I'm thinking that the social determinants, especially access to nutritious and healthy food, and then access to transportation. I mean, transportation is as important as the air that we breathe, um, when it comes to getting access to the medical care that we need. And so I just wanted to highlight those things.
Yeah, thanks, Emily. That's, that those are very key need. We do have a lot of questions on things that are, mm, I hopefully in alignment with some of the needs that you brought up. In terms of the position statements themselves, this is just, I'm not sure we go into that sort of detail, but there is definitely a lot more behind health equity, and I don't know if we have 4 bullet points here, right? And we're just it's a bigger document, and we will. I don't recall. I can't date for sure. That we address most of what you're talking about, but we will go back and take a look at that. But I know that your concerns. I think some of those, the family support. We do have questions on that. Um, in that, we transportation, food, housing. We do have questions on that. I will, as an Oregon resident, avoid the roads and transportation portion of it. But we do have a lot of these questions. I think we can come back to you, and we'll take a look at some of the RFP questions and get back to you on some of those things that you brought up, just to make sure we are looking at it. Take another look at it. We do have some information about some of the types of questions we have coming up, but it's not going to be. I just did a quick scan through it. It's not going to cover what you're talking about. So we'll have to get back to you on some of this. But we do have a lot of questions on. Hopefully, we do have a lot of questions on social determinants and health equity, and hopefully they will be in alignment. But we will double check. I don't know, Maggie. Was there anything that you maybe wanted to add on this?
No, I think you covered it, Emery and Emily. Thank you for your feedback. We will go back and look to strengthen our questions if we need to, and add any based on your feedback, if that's necessary, based on what's already drafted.
Thank you.
Yes. Anyone else from the board have any questions, comments on these first 4 position statements? Okay. So the next 4 position statements you can see here, we do have pharmacy up here in the top left. So they are crucial for managing. I mean, it's a huge part, as we talked about, 28+% of your care. And I think, with everybody using it, it's a huge part for here. And so there are, certain things that are needed to help members access, and receive the care, the pharmacy, the drugs that they need. And then also with some of the new drugs, I mean, especially with GLP-1s, that's been talked about quite a bit. We've been talking about it, and just trying to find a way to save and to create something, programs to help members receive those types of services. Top right, in terms of network and access, 3.4% limitations obviously up there, and the ways that you can try to achieve that 3.4%, high quality, equitable care, trying to embrace value-based purchasing, and also, fairly compensate and make sure that the providers are not feeling that they are, basically uh, having the issues, and that they're not being treated fairly as well, because providers are a key part of the overall system. There has been some things done, especially in terms of behavioral health providers recently in Oregon, but all providers, and we hear about strikes and other things like that, and that disrupts the healthcare system. And we want to make sure that disruption of the healthcare system isn't happening at whichever level it is. Um, so that's part of it. Data and reporting, it's just making sure we use data the best possible way, and to actually use it. There is a lot of it out there but how much of it is actually being used to proactively identify health conditions to help direct care before it becomes an acute situation. Uh, so addressing those gaps in care, and that integration, and making sure that behavioral health is being taken care of, and that if there are potentially needs, that's being there for, and that it's identified before those acute behavioral health needs come out. And then financials there on the bottom right, again, the performance guarantees, the performance and the commitment to work with PEB and Oregon to meet that 3.4%. It is, I think Oregon and healthcare's 3.4% are synonymous. And so, you can't be a partner with PEB unless you're willing to help PEB meet that 3.4%. And so whatever can be done in that case. So those are some of the other position statements. I will pause again to see if there's any comments or questions from the board.
It seems to me that these position statements have distilled a lot of the values that we have talked about over time, and I appreciate that work. Sean, I see your hand is up.
Yeah, I assume that we'll get into the details of this as we go. So I appreciate seeing the 3.4% as a position statement. It just kind of, as I was reading it, kicking it up is like getting past that kind of sentiment, like, yeah, like we'll try, you know, but really trying to get specific about like how. And I know we have some talk about performance guarantees in here somewhere, but anyway, I don't know how well. I'll just wait through the process, but I'm just attuned to that. Like, how do we get past the sentiment where it's like, yeah, we'll give it our best go. We agree that that's important, those kinds of statements, as opposed to like commitments and getting detailed about how they expect to accomplish that. So,
Yeah. Yeah, definitely. I hear you on that. There's definitely a lot more, especially in the actual RFP questions themselves that aren't, it's not going to be in this document. We're doing the presentation, but in terms of value statements and those questions, you might want to, I don't know, we'll talk about it internally. There may be ways that you can take a look at it and make sure it aligns with what you're thinking, because there's definitely a lot more behind the scenes, and we are trying to distill this. And so we will take it back and try to find a way to make sure that your concerns are met. We're just trying to give you a taste, and for a moose bouche of what's in the RFP in this case. Unfortunately, I don't know. It's not. I don't know if it's unfortunate. We just don't. We don't have like 3 days to go through.
Thank you, Emery.
Okay. Yeah.
And this is Brian. I want to weigh in just because today we're planning on asking the board to authorize us to move forward and work towards releasing the RFP. So I hear that we have a couple areas where we're going to report back to the board, but I just want to do a quick temperature check. Are board members still feeling okay that even with us reporting out, that up to this point, people are still on track to feel like they can vote to authorize after we get through the discussion, specifically for Emily and Sean?
I was going to share that I feel like we're on track and appreciate all the position statements. I know we're going to talk more in detail too.
And I asked more it's a logistical question. And then Sean.
yeah.
Okay.
Yeah, I'm on board. I just.
And as we move forward with today's discussion, if there happens to be a piece of information that any board members feel like I absolutely would need to know that in order to authorize just the overall project, highlight that, and then we can kind of triage things in real time as needed. And sorry for the interruption.
If I'm not mistaken, Brian, the timelines dictate that a go-ahead today would be ideal to let launch proceed, in which case, if there is additional information that we need to get to that point, and it's possible to do that we would like to have that in motion today. Am I understanding you correctly? You're still muted.
Yes, absolutely. In a perfect world, we would get the authorization to move forward today. But if there's a piece of information that's missing that gives some board members pause, then I think we can step back and talk about, okay, can we still ask for authorization today and make it contingent on, successful resolution of that item, et cetera. So again, I'm just thinking more from a logistics standpoint.
Yeah, and I'm it moving forward. Because I feel like the broader landscape is changing that I know we don't have control over. I just wanted to, I saw social determinants of health and just thought about the cuts coming, dramatic cuts for food and transportation and that. So Thanks.
And that was all great feedback and comments, Emily. Exactly what we want to hear. So no worries on this end.
Okay,
Thank you,
thanks.
Emily.
Yeah, thank you. Yeah, just one. Yeah, I think it's like you said, it is a big RFP, and hopefully this gives you a flavor of what's in it, the types of questions we're asking, and that you feel comfortable that we are moving in the right direction, and that this RFP should move forward. But thank you for that. So a little bit more detail on the medical questionnaire. We are going to go in some sections. I'm not going to go read through all of the items in here. There is a lot of text, but I wanted to again give you a sense of where we are, the types of questions we're asking. So moving on to the next one. So we do, I think, have one page on each main topic. So for member experience, just kind of to highlight again what we're talking about. It's about the interaction with the health plan. It's dealing with like care, especially episodic care with the chronic conditions. You have PEB members who are long-term members, who definitely need and want and used and value the healthcare system, healthcare that they get, and try to make sure that the member experience, long-term members, is there. And in terms of navigating those chronic conditions, because you don't want your members. It's like healthier members like improves the productivity and helps the state, and just everything along. It's a much more holistic thing. So so some of the questions you can see, or at least the topics of questions, and we definitely go and drill down in detail on these and get very specific. But it's just like things like the resources that are there. How do you help find the right care? Just describe it to prove that you can actually do it. What kind of return on investment you're having on this. Case studies you can see down below, kind of demonstrating how the bidders are actually doing these things, rather than saying, so what can you show us to prove you are doing this, and what kind of return investment you're getting on it, navigating acute care, chronic care, and then many questions about supporting equitable member experience. So a lot of these things that the PEB board has, been working on, a lot of the concerns that have been brought up. I think when we had the discussions during the retreat, those, hopefully informed a lot of these, the questions we're asking. But these are definitely some of the topics, some of the areas where we're drilling down in the member experience. So, again, it's not comprehensive, nowhere near comprehensive, but if there's something that you want to make sure that the work group working on the RFP is addressing, please bring it up, or I don't know, let us know it maybe after this board meeting, just to make sure that we are addressing your concerns, or just making sure that we are addressing the key areas where you think there are needs to focus on. Okay. So clinical services. So this is, again, very similar to what the member experience is, but it's really what the plan's doing to manage the member towards better health. So things like, how are you identified? What's the coordination? What's case management? The audit that was done was very eye-opening, and so trying to address some of those issues that were brought up there. Staffing, support, utilization management, all of those things, as special, and also some of the, in terms of health equity, some specific health equity questions. There's been equitable benefits. There's been an expansion. There's been inclusion of more different types of providers than just, let's just say, traditional, right, healthcare system. So how are the plans doing this? Have they done this? Are they going to be able to make sure that they are able to do what PEB has put in, with fertility doulas, gender affirming care, and just meeting the needs? Because these are key areas that have been, implemented, they're new. There's been lots of questions, concerns brought into it. And, we don't want to have those questions and concerns because it does impact members, especially in some very important, sensitive areas, parts of their lives. And again, I will pause to see. Okay. So network strategy and access. So, it is dealing with the contracting and with the providers. A lot of questions again around access, high quality networks. You can see here at the top. Some questions, making sure that it's just making sure that providers want to be in the network, and providers feel like they're providing have the best ability to provide the high quality healthcare for PEB and for just any Oregonian in this case. So how are the plans going to be doing to address these? How are they helping support in this case? And also with PEBS network and the primary care patient-centered primary care medical homes and Oregon initiatives. How are you going to do this? How are you going to ensure that these providers are still supported and part of the network? And then down below, value-based payment, other things like that. Um, Disruption, of course, is a major concern for PEP. Identifying the potential disruption, with the, not just the alternative care services that we heard earlier today, but just disruption in general, behavioral health. Trying to enhance behavioral health networks and things like that, and making sure that there is congruence in the provider network and helping support PEBS initiatives in identifying, creating a network and a network that can be easily, I think, I don't know if it's accessed, but like understand who you're getting care from, and that you can find a provider that is understands the members, right, in all facets of how the member is, and also it's not just the urban areas, it's rural areas. There's huge, and we will show some of the employees in some of the other outlying non in the rural areas, but just making sure that the members in those rural areas have a network that's actually robust um, and quality in this case, and also traditional and complementary care. Hopefully, Emily, there's definitely some questions around that. We can provide more detail again, but we do have some questions on that. Okay. Next slide. Data and reporting. So a little bit less in here, but definitely not. Well, I don't know. There's a lot of questions that were written, but some of the top things is like it's really trying to get better outcomes for members, and how are the potential bidders doing that using data to drive better outcomes. It's kind of in alignment with, I think, the Garner solution, right, in terms of trying to find the high quality, cost efficient providers. But it's like taking that and also expanding, just and looking at cost and quality, which is very similar to that program, but also making sure that you understand how number of members are being engaged, how they're being engaged, and creating solutions as a result of finding issues around engagement with just general healthcare or all the point solutions as well. How are what's the plan potential bidders doing to help providers improve care for members? I think that's a big thing, the reporting and just identifying, understanding, and the metrics, and just being able to understand, segment the populations, stratify the populations based on real D, SOG information, chronic conditions, other social determinants, those sorts of things. And how is that data being used? Because it is, it's getting there, getting the real D and SOG. It's not ideal yet, but making sure that the plans, helping implement those, and then using that data, because the data is there for a reason, and making sure that the data is used in ways that actually improve the members' health. So those are some of the questions that we have. Yeah. Service administration. So it is making sure plans are running well, right? So this is a little bit more technical. The board members, the scores probably won't have very much in this. This will be like more of a staff Mercer section, but just kind of like plan services, how are you going to assist with legislative and other needs that staff might have, integration with, other vendors, claims databases, other systems, those sorts of things, ID cards and other things. So it's, again, more technical, but some of those just nitty gritty detail questions. Next section. And then financials, again, trying to meet that 3.4% limitation. So this is just, again, just the bigger points. Really, it's like, so we are going to look for administrative fees, fully insured premium rates, but we will also ask about contracted provider facility rates. Percent of Medicare, obviously, is a way that Oregon PEB has been measuring how well contracting has happened. And that's going to be part of the requirements, being able to actually price out on a percent of Medicare, ensure that you're meeting that limitation. But that's also going to be part of how we measure each plan in terms of what kind of value that they're going to be bringing to PEB. So we will be asking to take and compare the contracted rates. And we will also ask to see what kind of value-based payments, because that has unfortunately fallen a little bit by the wayside with the 200% of Medicare. So what sorts of value-based payments, how can the plan integrate with that to kind of make, I don't know if it's, fee for service is a way to pay. It may not be the best way. It may not provide the best incentives for paying, but so it's like what can, in terms of value-based payments and other things can be done to achieve that. And then performance guarantees, what quality metrics, trend rate guarantees, requirements, performance guarantees around implementing and measuring and segmenting and implementing things around social determinants of health, network requirements. In terms of access, performance guarantees around making sure access is there for all members, urban and rural and out of state. And then advocacy return on investment, because an advocacy solution is great, but not if it's just going to raise prices and you're not actually willing to stand behind how that's going to be helping the members get better care and reduce the cost for PEB. So those are sorts of the questions that we're going to be asking about in this case.
In this case, Emory, advocacy, return on investment, and other guarantees refers to the sort of care navigator advocate models.
Yes.
Is that what that means?
Yes.
Thank you.
Yes.
Yeah.
Yeah, it's so yes, yeah, it does. And in terms of the member experience, we are asking for like a very robust member experience. We're asking for a lot of services, and for those services, they should be able to demonstrate, it will provide these sorts of utilization improvements, member outcomes improvements, member experience improvements, and financial savings. And so it's just demonstrating, that it's like, I think we talked about earlier, providing some actual documented proof that you are doing these things and that it's actually providing that return and that you're willing to stand behind the fact that you're providing this, right, and providing a savings to them. Okay. So I know I've been talking a lot. What's the next section? Okay, so after this, we do have the pharmacy questionnaire. And with this, I will turn it over to Sarah. And I think we do have a break right in about 7 minutes. Sarah, I know I talk a lot and maybe I know it's too much, but so I don't know if you can get through some of these slides before the break.
Yeah, I'll try to get through them at a high level, and then we can break. And so when we're looking at the pharmacies, some of the first things we want to look at is minimum qualifications. And so, there's some things that we just see as table stakes for this RFP. And if the vendors aren't willing to meet these minimum qualifications, they would not continue to further scoring. So for example, we want to make sure that 100% of any rebates that are coming from pharmaceutical manufacturers are shared with PEB, including manufacturer fees and other fees. We really don't want to see a setup where the PBM is retaining some of those rebates. We are also wanting that the bidder is willing to provide disclosure of those rebate agreements with the manufacturers, that they can be audited, that exclusions have to be well-defined and not open-ended. Sometimes we'll see PBMs will say something, this type of drug, as an example, this kind of drug can be excluded rather than clearly defining what will be excluded. And so we want it clearly defined so that you always know what the deal is. We're asking for the broad retail pharmacy network, not a narrow network. Again, recognizing the importance of pharmacy access to PEB and the members. And then just some agreements around customer service, implementation, and compliance requirements. We do have a required bid template, which is an Excel spreadsheet in addition to the questionnaire and the proposal tech, and that's what's needed for us to be able to complete the pharmacy analysis. We are requiring any potential bidders to fill that bid template out in its entirety in order for us to consider the bid. You can go to the next slide. So we're looking at the pricing offers, and like I described previously, it's not just the dollar amount, it's also what's included and what's excluded in that pricing offer. The goal here is to make sure that you're best positioned to meet that 3.4% limitation. We want to understand, so I talked about no spread, we want pass-through pricing. We're also asking some specific questions around how the PBM is addressing fiduciary concerns, especially around what we've seen in the market, some egregious pricing on generic drugs. So we're asking the PBM to specifically talk about what they're doing there. How they use MAC, which is a pricing tactic for generic drugs. Talked about inclusions and exclusions. We're, in addition to just the rebates and the discounts, we also want to consider how the PBM is pricing additional fees, like production cost. Are they going to charge you for posting? Postage, are they going to charge you for having multilingual capability? All of the different add-ons, we really want to understand what the fees are so that we can incorporate those as well. We're asking if they're willing to do trend guarantees and what the reconciliation on those would look like. And I talked previously about how we want to make sure that PEB has the right to a market check so that those terms can be updated frequently enough so that you don't get behind on your pharmacy offer. And we would, the process for evaluating the pricing offer is we will use actual utilization data from PEB, and we will model each vendor's pharmacy offer against your utilization data, assuming they meet it through the minimum qualifications. And then the scoring would be structured so that for the financial component, so that the projected lowest cost offer would receive the most points. Let's go to the next slide. Looking at network and network disruption, the vendors will be asked to submit a geo-access analysis for the retail network so that you can evaluate the pharmacy access for each vendor. We're asking them to notify PEB in advance if a pharmacy is going to be terminated for the network and provide a report of the impact to members. We want to make sure that the pharmacy can accept returns, destruction, and make sure that PEB isn't billed for that. We think it's important that there's a disaster recovery plan. We're looking for audits of the pharmacy network to make sure that the network is adhering to the PBM and PEB's policies, and that any recoveries during audit would 100% pass back through to PEB. We want to make sure the PBM is capable of immediately suspending any pharmacy from the network that is engaging in suspicious claim activity, and that PEB could be reimbursed for fraudulent claims. We don't want this to happen. It doesn't happen a lot, but unfortunately, Sometimes there are bad actor pharmacies, and we want to make sure that the PBM is keeping them out. And then we're also asking for a list of non-traditional mail order providers that PEB could elect to include in the network. There's been some interest lately in some of the non-traditional vendors, as an example, like Mark Cuban, Amazon Pharmacy, some of those direct-to-consumer mail order pharmacies that are offering lower prices on some medications. We want to understand if that's a possibility for PEB members from these PBMs. You can go to the next slide. Talked about formulary disruption. So we want to understand how many members might experience disruption, both in terms of tier, like a medication going from tier 2 to tier 3, it could have a higher copay, or drugs that could be excluded from the formulary that the members are currently taking. We're asking if the vendors will agree on a limitation once implementation occurs that less than 1% of members would be affected by the formulary changes every year. And that's just to limit the amount of disruption that members experience on an ongoing basis. We also have a standard question that, will the vendor agree that if a drug was excluded in the past, it's added to the formulary, that then it needs to stay on the formulary for 2 years. And this is just to prevent, sometimes what we'll see is members experiencing like a yo-yo where it's on again, it's off again. We're looking for stability in the formulary and then wanting to understand what the PBM's communication process is related to formulary changes. So in addition to the scored questions, we would do a formulary disruption analysis, and that would quantify the number of members and number of prescriptions that could be disrupted by each vendor. We go to the next slide. So clinical capabilities, here we're trying to understand what each of the PBMs offers in terms of clinical programs and management in their specialty pharmacy. There's a lot here, and I'm not going to go through it in detail, but I do want you to know we are asking them to describe strategies around weight loss and diabetes management. We know the GLP-1s are an important topic for you and your members, so we want to understand what each PBM can offer in that category and how that could offer you both savings and access. Also, a couple things to highlight. We are asking about opioid management. I know that was important to PEB. And then just generally, we want to understand how they manage their specialty pharmacy, how it's staffed, will members have access to pharmacists, and then what kind of drug utilization management and drug utilization review the vendor can offer. We can go to the next slide.
This is quite a lot.
Yeah, it is. It's a lot of questions. It takes a long time to get through it. I would agree. It can be a lot. And I will say I've been a part of RFPs where we don't do a full questionnaire. And sometimes there's a risk of things getting missed if we're not asking some of these detailed questions and incorporating them into the bids. So we want to make sure that we're looking comprehensively at the PBM. Transparency reporting. I talked about this before. We really want to push on transparency. We talked about that at a previous PEB board meeting. So we're asking questions, not just around the total revenue disclosure, but clinical decision-making. Will the vendor make all of their P&T committee meeting reports available to PEB so that you can read how formulary decisions are made? This was a suggestion from one of the PEB board members. What efforts does the PBM take to limit the manufacturer influence on formulary decisions? So really trying to make sure that the decisions are clinically based and not manufacturer influenced. And a lot of these other questions are around the level of data and the frequency of data reporting that would be available to PEB from the vendor. I know in the past we've struggled a little bit to understand if we break down by therapeutic category, for example, of your spend, what is the net spend or how much is it growing once we consider rebates? Today, PEB isn't getting a level of detail that allows them to answer that question. So we're in this round of RFPs, we're asking for that level of data and looking for a partner that's willing to provide that level of data.
Sarah, let me just check in about how many more slides we've got here.
I believe there's 2 more.
Is it just
think there's two
two?
more.
Okay. Yeah,
Yeah.
let's go ahead and finish up pharmacy and then we'll take a break. Thank you.
Yeah, sure. The other one I wanted to call out here is if the vendor owns pharmacies. And we're seeing a lot of interest in this on vendor owning, not just retail pharmacies, but specialty and mail order pharmacies. So we're asking the PBM to provide information on, what is the amount of margin that's being made from PEB members at those specialty and mail order pharmacies. That's part of that total revenue disclosure and understanding where the PBM is making money. All right, let's go to the next slide. This is around service and operations and just making sure that the service model, both the member service and the service to staff and the PEB board is the right fit. So we're asking about how the account management structured, like who would be your day-to-day contact? What are the expectations around reporting, audit rights, communication and tools for members? Things like member web tools would fit into here. Understanding the mail order and the specialty facility operations, there's questions there. And then we're asking about termination rights as well. So, if for some reason the PBM isn't a fit for PEB, sometimes we'll see that the contracts are structured if you were to leave early, that the PBM will retain a quarter or two of your rebates. We're looking for the ability to be able to terminate if it's not a fit without penalty. And then asking about subcontractor disclosure, wanting to understand who are the subcontractors that might be being used. All right, next slide. And then performance guarantees. So this is somewhat similar to what we're looking at on the medical side, with the added complexity with pharmacy, because the claims adjudication is real-time point of sale. There's a fair amount of performance guarantees around that point of sale processing. So we're looking for implementation guarantees around the benefit setup, accumulators like deductibles, out-of-pocket max setup, and how that can integrate with the medical plan. But then also ongoing performance guarantees, things like system availability. You don't want a PBM that their system goes down, for 8 hours a day and members need their prescriptions overnight, right? So wanting to understand what the system limitations are, wanting to understand their call center for pharmacy. Phone calls to PBMs tend to be some of the more common calls that come into the call center. So how quickly are they answered? How many are abandoned? And what portion of calls are resolved on the first call? Looking at claims processing accuracy, and then mail and specialty accuracy, timeliness, and then guarantees around account management satisfaction. So all of this big picture is just to make sure guarantees that the PBM will deliver on the service as promised. And so that's what we're asking for here. I think with that, that's the end of the pharmacy section, unless there are questions.
And while people are thinking about questions, I think just for Sean and Greg and anybody who might actually want to be a scorer, as a board member, you won't be scoring all of these questions. Most of these questions are going to be done by staff and Mercer. So there's definitely a select list of questions that's participating, but this is, just wanted to give you, I don't know if it's all the gore details, but, it gives you the, the sense that hopefully we are covering a lot. It is a lot, and that, we are being in depth and hopefully meeting the needs of what PEB's looking for. Just want to put that out there. Sean.
So yeah, it's just a technical question here. So let's say that we have a vendor. I thought about it while we were talking about pharmacy, but it actually is the same question for the medical side. But let's just say for the pharmacy, to keep it simple, there's a vendor. Let's say it's a national vendor, and when we're asking them about the network or the reach, how do we score them if they have to already know what the network is, as opposed to statements where they're like, well, we'll contract with blah blah blah, sort of being naive to Oregon's actual market, and they're like, well, I'm sure we'll be able to get prices like this, we usually do in every state. And it's like, yeah, well, you haven't tried in Oregon. And it turns out that there's some monopolies around, so what are you going to do? And then they get here and they're like, oh, well, we couldn't get those prices we said. So how do we, does it, they have to have like preliminary contracts in place or something in order to apply? Or like, how do we score that? Or how is that filtered, I guess?
Yeah, so I think this is like maybe a little bit more detailed question that maybe we can talk a little bit offline, but we do, uh, I mean, we will basically do a disruption, right? So it's going to be based on the network that they're proposing. So it should be the contracts that they currently have in place. And then we will take a look at uh, who PEB members are currently using versus who they have in their contract in the network. And so that's really the disruption portion of it. Actually, I think disruption is a big part of it, and we talk about it in more in this section coming up. But just making sure that uh, PEB members aren't going to have to change who they're seeing is essentially a calculation that we're going to come up with, and that's how we score it. And then the financial considerations around that network will then be part of the second portion of it, right? The cost that we will analyze in this case. So I think it is, you know, it is pretty much I don't know if it's a requirement, but but it shouldn't be a fake network, right? It has, it has to be the contracted network. It's the network that they're providing. And if they don't actually, those providers aren't in the network. I mean, I don't want it to be a situation, but there would be issues on the back end that I think PEP would be taken care of. And that's more of a Brian and Ruby concern there. I don't know, Sarah, if there's anything else that you wanted to add on that.
Yeah, generally for pharmacy, we ask them to propose based on their current network. We will send them a list of the pharmacies that are currently being used by members, and then they have to identify which are in their network and which are not. Yeah, the question, like Emery says, if they're providing information based on a network that doesn't exist yet, that's a different question. But by and large for pharmacy, because the PBMs tend to be have a broad network because people move around to fill their prescriptions, it's usually not a big issue where we might see that they don't have contracts in a specific state or a specific region outside of the issue around rural access, which I think is more than just pharmacy.
Thank you for that. And with that, that was a lot of questions to Rapnosa's observation, and not just about this, a lot of questions about this and about medical. And it gives me confidence in the process to know that all of these things are going to be interrogated in advance, and the values we've described brought to the negotiation. With that, I think we will go ahead and move to break. It's 11:21. Let's go ahead and return at 11:30, and we'll get going again. Thank you to our speakers and to all of our attendees. See you in a few minutes. Hi, Siobhan. Thanks for coming on camera. Emery, welcome back. I'm looking to see if we have a quorum back. So thank you, Sean and Emily, for coming on camera. If you see the others, please say so. Take a look. Andy, hi. Okay. I think we're there. Welcome back, everybody. Thanks for coming back. I hope you had a chance to stretch your legs, maybe get a breath of fresh air. We are going to proceed with the next item on our agenda. And again, there is action requested about this. So let's be sure to identify any questions we need to get answered in order to take next steps, whatever those are. Ruby Castañeda and Brian Olson, are you with us?
Yes, I am here.
Hi, Ruby.
Hello.
Are you prepared to proceed without Brian? I don't see him back yet.
Yeah, that's fine.
Okay. All right. The floor is yours.
Yeah. I'm back. I'm just Ruby's taking first chair on this, so I'm here and ready.
Thank you, Brian. Sounds good.
So in the next section, we'll be talking about the RFP evaluation and selection process. If you want to move to the next slide, Maggie, that'd be great. So in this big RFP, we have various mini RFPs, if you will, within the larger portion of the RFP. The one was about the pharmacy, only information, the statewide PPO, and then the coordinated care model. As Sarah had indicated, it's not unusual to have a pharmacy that is not integrated with a medical plan. So we have our statewide PPO, which is for the state of Oregon, and can also be included statewide within the United States. And then we have our regional, more coordinated care models where it's specific based off of like certain areas or certain counties within the state of Oregon. And in doing these many aspects of the RFP, they all have different levels of criteria and questions associated to them. And let's see. If you want to go to the next slide, Maggie, that'd be great. So in terms of the coordinated care model, we went ahead and utilized it and broke it up by certain regions or areas within the state of Oregon in order to be able to select a potential apparent selected proposer for each region, and not each region doesn't have to have only one proposer bidding. It could be multiple, and the board can choose to have multiple plans within a certain area. And so that will be a board decision, and we will be looking for the board for that information. So as you can see on the map, there's 1, 2, 3, 4, 5, 6 areas that we had focused on in terms of being able to break the state of Oregon into certain specific regions to get or assist in selecting proposers that would encompass the state of Oregon and all of the PEB employees. Next slide, Maggie. So the overall scoring, so there's going to be different areas. So there's going to be the written area, and then there's also going to be the finalist area. So the written section, it's broken out into the medical as well as pharmacy, and as well as the finalist interviews as well. It's also broken out into medical and pharmacy. And we broke it up at a high level where 75% of the written information is going to be evaluated and scored, and then the other portion of it, which is 25% of it, will be for the finalist interviews. Next slide, please. And this is broken up even further in terms of specific topics that are part of the PEB's, sorry, of PEB's vision in terms of member experience, clinical services, network and strategy, data and reporting, services administration, and then the financial pieces of it. And so it's broken out where the medical questionnaires are one section, and then the pharmacy questionnaires are also scored and evaluated based on those specific high-level categories. As you can see here, it just shows that information. Are there any questions in terms of the scoring level or percentages that we came up with? Seeing none. We will, and as indicated in that little drop down box, it says like there's a lot of information in terms of advocacy, behavioral health, and health equity incorporated in each of these sections. So just wanted to point that out and clarify that as well. Next slide, please, Maggie. So the questionnaire evaluation and process. So we will have evaluator training. And we will have all evaluators conduct this training. And part of that training was doing a conflict of interest. If you're a voter, if you're voting a board member, then you would have to do the conflict of interest. And then if you're also doing evaluation, you would also have to do a conflict of interest that not only pertains to board members, but that would also pertain to staff and as well as Mercer staff to ensure that there isn't any conflict of interest when evaluating. And then we would do the review process. So once everything has been scored and evaluated, and we see the information of like, yes, they are meeting all the minimum requirements, and they have all the information there to be able to proceed to the evaluation, then that's what we're looking for. So there's the second part would be reviewing the completeness of the RFP and how they answered all those specific questions that we asked for. And then that's when we move on to the scoring and process. So that's where the evaluators will start to score the information, and then Mercer will do their magic and making sure that everything that everything is matching the way it's supposed to be matching, and that we have come up with a determination of who we think are the people that the proposers that will be moving on to be able to do the finalist interviews. If you want to go to the next slide, Maggie. Oh, Andrea, you had a question?
Oh, I just wanted, I think you said it earlier, and I think it's one of those days where I'm super tired. But when it said proposal is not contingent on being the only plan in a geographic area, is that, I'm trying to think, do we have that issue now? I'm just trying to figure out when that comes into play.
So that usually comes into play within the coordinated care model. So you could have more than one plan within a region, so like the I-5 corridor. So you could have the statewide plan along with a regional plan on top of it, you know, so that way
Okay.
Yeah.
I didn't realize that there were groups that only wanted to be in one area.
Yeah, a bidder can go ahead and do that if they choose to.
Oh, got it. Okay. Okay.
Yeah.
Thank you.
You're welcome. Any additional questions, clarifications? No? Okay. So the ranking for the finalist selection is pretty complicated, and we did a lot of due diligence to try to make sure that we incorporated all of the different avenues and aspects that would be that the board could make a good informed decision on. So we have the medical plan only, and we will use their scores and score it with the highest ranking pharmacy proposer. So that way we could have the combined medical with pharmacy. And then we will do a equivalent comparison to the combined medical pharmacy bids. So those that are integrated, if you will. And then we will use that for the statewide and then the coordinated care model rankings. And from there, once we have all that scored and evaluation, we will come up with our top 1, 2, or 3 proposers. And we'll do the exact same thing so that would be for the statewide, and then we'll do the exact same thing for the coordinated care models as well, where we come up with that, if you will, apples to apples and oranges to oranges type of model to make sure that we're selecting the highest scoring bidders. And when we're doing the rankings, we're going to be ranking the pharmacy first. And then from there, we're going to do the statewide or the PPO plans. And then we're going to go more towards the coordinated care regional models, if you will, because that just makes it easier for us to be able to mix and match, if you will. If you go to the next slide, Maggie. So once we figure out who our highest ranked pharmacy is, we will match them with a medical plan. And so the way it'll work is once we have that information, there's going to be some caveats associated to that. So that way, if the board chooses to, they can go ahead and go to a lower ranking proposer, should they choose to. So we have some caveats associated to that. So that way, it's not a, so that way the board has options. So the final scores to determine ASPs will be weighted by the 75% of the total score on the questionnaire, and then also on the BAFO, which is going to be 25% on their finalist interview. And we will open it up for certain areas for finalists, or for them to go ahead and look at open up certain questions, so that way they could go ahead and submit their best and final offers to us if they get to that stage in the selection criteria. And then finalists will be invited to participate in the finalist interviews. We don't know how many there'll be, so that's all yet to be determined. And then finalists will be required to provide their presentation materials in advance before the interviews. And then, like I had indicated, they will be able to do a best and final offer.
I need to get ready for tennis.
And sorry, that's my son. If you heard him in the background. And so, are there any questions in terms of the mixing and matching? Okay, seeing none, we will go ahead. Oh, go ahead, Dawn. I saw that you came on.
Thank you. The regional coordinated care model looks like a simplified map of related to the OHP CCO regions. That is it's a way to approach this that I hadn't understood, that we were taking this in this RFP, and I was wondering if someone could speak to how we came to that as the best solution. I do recognize the sort of differential challenges in the different locations, different regions of the state. Could someone speak to that, please?
Yeah, Emery, do you want to speak to that?
Yeah, sure. So it is kind of similar to what the CCOs have, right? In terms of some of the regions, it's a little bit different. I think it's like Northwest, Tri-County, Southwest, and then Eastern. And then some of those locations like Central Oregon, Eastern Oregon would be combined under CCO. But for PEB, what we wanted to do was to kind of take a look at the populations, right? And also kind of like the health systems and the plans and where they kind of operate. So that was part of what what was considered in breaking out these regions a little bit differently. Um, so in the metro area, obviously you have pretty big concentration, 23% of the employee size, and these are a number of employees that would be eligible for medical. So 15,000 employees. And there's competition, right? In the metro area, there's different plans. You have, Kaiser with its own plan and their own providers and own facilities. You have other plans, Moda and Providence have their own affiliations. And there's multiple competition, multiple provider systems there. It's kind of similar also along the I-5 corridor. Um, so, for in terms of Kaiser, they've moved into Lane, but uh, they're more northern tri-county area. But there's also other multiple competition, but the competition's a little bit different in the I-5 corridor, and the population base is a little bit different. So we kind of broke those out in that case. I think that's a little bit more of a nod as well to the CCOs, where the tri-county is broken out versus some of the others. But it's just like in terms of how healthcare is delivered, we felt like those were and how members are and people live, where people live. I think we felt like this was two kind of distinct sections, distinct regions that could be different in terms of the types of plans that would be bidding as well. So that was part of that was the bigger bulk. And then we go into these other sections where I think it's much more regional in terms of the healthcare and the healthcare systems in there, and maybe the relationships with the plants. And these regions, the coast, Southern Oregon, Central Oregon, Eastern Oregon, are smaller in terms of population. And this is where we wonder whether there's going to be enough ability to actually have competition. It might be better to get better leverage to have one potential coordinated care bidder in this case, because it's like you're going to have a lot of overlap in terms of providers and the facilities. There's only like one hospital in a lot of these sections. So in terms of the way care is in Eastern Oregon and how far you have to drive versus Central Oregon, especially with like the Bend area, and then you go up towards Hood River and um, gosh, I'm blanking on the Dalles, right? In terms of those providers, it's a little bit more centralized. So it's a little bit different in my opinion versus Eastern Oregon. And then you have Southern Oregon with the cities and the hospital systems. And then the coast, you have a lot of people driving up and down, and it's very kind of like localized in that case. So we kind of, in terms of the breakout, it was kind of taking a look at how we've looked at it in the past, as well as how care is kind of delivered and just the systems that are there. So that's kind of like the way that we looked at it. It's definitely open for questions, considerations. If you're looking at this a little differently, if you think combining would make sense, or breaking it up a little bit more, but definitely open to that. And Brian, you came off of mute as well, so I don't know if you wanted to
Yeah,
add some stuff.
I was going to say, you did a great job of emphasizing how we try to look at the market dynamics in establishing these regions. And one thing I want to emphasize too is logistically, breaking up in regions is going to help the board really focus when it's time to select the final winners in the various areas of the state. Without getting into too much detail, if we didn't break it up into regions, it becomes a lot more difficult to determine which regional proposals are in competition. Some may not be in any competition. And so this is a way of kind of chunking it out and being very, I would think, intentional about how we're going to ask the board to select the winners at the very end of the process. And that's something we'll get into in a few slides from here.
Thank you. That is exactly the question that I had, and especially sort of this setting up kind of a cherry picking as well, and wanting to be sure that the rural regions where the challenges are most fierce are getting their appropriate attention. And it sounds like you've been very thoughtful about that. So I'll look forward to learning more about it. Emily, I see your hand is up.
Yeah, thank you so much for asking the question, Dawn. I also had sort of a similar question, and I appreciate that explanation. So that helps me as well. But I just wanted to add, because we're talking about diversity of providers, and I'm glad that we're thinking about providers, but culturally and linguistically appropriate providers, and how each region has different demographics. I'm just wondering, is there an opportunity in the process for the evaluators to get grounded before they start evaluating, even on what are the demographics of those regions? So you know, for I know I helped to evaluate the health equity plans for during COVID for local public health. And, you know, for sure, like each region has different demographic makeup, like in terms of culture and language, and then age, and, you know, other things like that. And so I just feel like that was real good foundational information for us evaluators to have, like at the get-go, you know, like what are the demographic, what's the demographic makeup of this like region? And I don't know, maybe that's too detailed for this process, but that was just helpful for me in evaluating different proposals in the past in Oregon.
Yeah, I think what we could do is, as we firm up all the questionnaire items and finalize them, we can look specifically at what board and staff members will be scoring and think of whether there's any contextual information that we need to provide to help with evaluation. As mentioned earlier, we are planning on having evaluator training sessions.
Yeah.
In the past, we hadn't drilled down to the level of where we're going over, you know, demographics or different characteristics of each region. But I think we can revisit the questions we're going to have you guys evaluate and kind of reassess whether some other information would be helpful to provide contextually. Um, you know, for the most part, you're just looking at the question and the response, not necessarily in a vacuum, but you are scoring based on that specific, you know, response. And I think in most cases, you know, that's all the evaluator is going to need to, you know, to score that specific item. But we can reassess and re-examine that.
Okay, yeah, I know Census 2020 data is so different from our Census 2010 data, so thanks.
Thanks, Emily. Rob Repnos, I saw that you came off mute, but I'm not sure whether you had something you wanted to lean in on here.
Nope, I'm good.
Okay. Back to you.
Okay. Thank you for that great conversation. I'm glad that we were able to provide clarity. If you go to the next slide, Maggie, I think we covered this one already. So in terms of the finalist interviews and the logistics associated to that, it's going to occur over a 2-week period. Just to give you an outline of what we anticipate it would look like is that we would have the combined medical pharmacy finalists, which would be 2 hours and 15 minutes. And then the medical only finalists will be 1 hour and 15 minutes. And the pharmacy only finalists will only be 1 hour and 15 minutes as well. So we would go have a brief introductory and closing remarks. And the medical portion of finalist interviews will include 3 questions that are common to all medical finalists, and that will be common to all medical finalists. And then 2 that will be unique to each proposal. And so if there's any kind of question that the board feels would be a good question to have in terms of like what they would want to see in a medical finalist interview or pharmacy as well, you know, please, you know, give us your feedback or your thoughts on how to incorporate something. And then pharmacy portions of the finalist interviews will include 8 questions. Those 8 questions will be common for all of them, and then 2 questions that will be unique to those individual proposals. And then, Sean, go ahead.
Yeah, so just to clarify, so is it 2 hours and 15 minutes for all of the finalists or like per finalist?
It'd be, so the first portion, which would be the combined, which would be the medical pharmacy, that would be 2 hours and 15 minutes. And then when we're mixing and matching and grabbing a pharmacy to interview with a medical, their portion would be 1 hour and 15 minutes. And then the other portion for the pharmacy would be another additional 1 hour and 15 minutes. So the combined would be 2 hours and 15 minutes. And if you want to look at it in terms of the medical finalists, combining that with the pharmacy would be about 2.5 hours.
So I guess
that
what I'm
make sense?
saying
So
is
Sean,
let's pretend that we have let's pretend that we have two combined medical pharmacy finalists that are close to the same score, right? Is the intention that we're going to try to score them to such a point that only one of them is left to be interviewed? Or if there were two that were really close, that we would interview both of them and they would each get 2 hours and 15 minutes, or they would split it, or how's it work?
Do you want me to jump in? So I was
PB?
going to say,
Go,
so
go
when
ahead.
it comes to selecting the finalists, after we go through that whole process of, combining stuff, so we have two full ranked lists statewide versus the coordinated care lists. The first thing we'll do on the statewide side is just look for natural breaks in scoring. So it may be that 4 or 5 statewide proposers are grouped up at the top, and we feel we're going to recommend that the board consider them all for finalist interviews. When it comes to the regional selection of finalist interviews, it gets a little more complicated because we're going to do it again on a region by region basis. So since not all regional proposals will be in competition with each other, that may mean that there is a rationale for us to invite a finalist or invite a proposer who has a lower score, let's say on a regional plan in Southwest Oregon, and not invite a regional proposal who has a higher score than that, but somewhere like in the Willamette Valley where they're currently ranked at 4th or 5th in the Willamette Valley. So let me stop there. I want to make sure I don't get too far ahead of
Yeah.
The
So
answer.
Sean, these are for each potential finalist in terms of the times. So it's 2 hours, 15 minutes for each potential medical pharmacy finalist, and statewide and the coordinated care are separate, processes. So they'd have separate interviews. And that's why if you take a look in the box on the left, it is expected to take a couple weeks because we have to schedule all of these, talk about it, and do other things. So it is kind of a little bigger process in this case, but it is, we would give each finalist their full time.
Okay.
And the other thing I just want to add is we're going to get into the winner selection soon. And when we're selecting the winners, we've built in additional criteria that really complicates the process a little bit. And hopefully we can explain it clearly because it took some time for our team to get wrap our heads around it. And because of these criteria, those criteria are another thing we would take into account when recommending actual finalists, where if someone still mathematically could be in the lead or in the running to potentially win, even if they're further down on the list and they have some things about their proposal that is important to the board, then it's possible we would recommend that they move on to the finalist interview phase.
Okay. So what I'm hearing, this is I'm getting into logistics just because we got to land the plane at some point. So what I'm hearing is that it's a pretty significant portion of a 2-week period the board members should really have blocked off for many meetings, as there could be, at least a half a dozen different interviews of more than an hour each.
When
Maybe
you
more
say
than that.
board members, specifically board member evaluators. So there'll be 2, maybe 3 board members. We haven't
I
built
thought
it to
the
where
whole board was doing finalist interviews.
that is an option we can definitely discuss today. We did not design it that way because of the public meetings implications. If we have more than a quorum of the board participate, score, evaluate in finalist interviews, they are public meetings. And while we did this in 2013, it really complicates the logistics because, long story short, we're going to be asking questions that are probably going to require proposers to share information that could be either sensitive or protected under public meetings law. And if we have a full board, then we have to work out how do we go in and out of executive session? How do we safeguard that information? And it really complicates how to organize the finalist interviews and still make them flow. So I think one thing we're talking
thinking
about
the
is actually recording the
scorers.
finalists. Oh, sorry, I think I cut you off.
So we're talking about the scorers who did the numeric scoring, also doing the interviews as a follow-up. Is that the idea?
Correct. That's how
And
we've designed it. Now, and Ruby, do you want to jump in? Because we can open it up to discussion if that's something
Yes.
that's important to the board.
Yes.
and so when um so right now we only have 2 scorers. Is that the idea? Correct.
Yeah, and we're looking for a third if anybody wants to volunteer. But
Ruby, I
they're
can
not the.
volunteer.
Oh,
It's
okay.
Andy. I can
Oh,
volunteer.
awesome. Thank you, Andy.
Great. Yeah.
Um,
So if that group's doing all of that, it definitely seems like we want 3. Yeah. Thanks, Randy. And then okay, that makes sense. Just speaking for myself, as soon as like I'm already getting conferences and various other things scheduled for the fall, like I know it seems like a long time, but it's not. So like as soon as we have an idea of what 2 weeks we're talking about, that'd be great if someone could like send a general hold, at least so I know what we're talking about. Because I probably already have to start adjusting stuff. So that would be great. And then, so help me, I know that this is in the slides, but since we're just talking. So then how would the full board, like when's the final decision, and how's the board engaged with that? And like, how do we actually land the plane, once those interviews are done?
So we would go once we are able to come to a final score. We would go ahead and indicate to the board, these are our finalist proposers. These were the highest rankings. And then we would lay out the exception criteria. So that way the board has that information in hand to make an informed and informed decision on which proposer we will go ahead and proceed with. And I don't know if I'm missing anything else. Brian, Emery, do you guys want to weigh in?
I was going
Yeah,
to mention, I
so
think. Oh, go ahead, Emery.
no, you can talk first.
I was going to mention that one thing we're exploring is recording the finalist interviews, potentially to share with all board members before the final decisions need to be made regarding selecting the winners. So that'd be information that the board would be potentially privy to. And I think we have the actual process coming up in the next few slides. I did want to reiterate, just for context, I probably should have spoke up early in the meeting, but an RFP, request for proposals, it's a competitive process. So just the default rule is usually the highest scoring proposal wins. Or if you're picking multiple, the highest ranked proposals win. And what we're going to get into in a few slides here is we've designed the selection process so that if there are, more than one proposal that's really grouped together, really close at the top, there's additional criteria the board can look to that could expand their options for selecting winners.
So, Sean, I think your question is really kind of, I think, what we want to talk about in the next few slides. So, I mean, we could move to that in terms of just essentially creating. Well, I mean, we talk about creating a finalist list, but really after the interviews, you know, we would essentially have that score, right? You would do your scoring, which I think is actually on the next slide. So maybe we can just talk about that real quick. But we're going to meld that score with their written answer, and to get to a final like points for each proposer. And based on those points, we will create a ranking list. There's going to be different processes for the different ones, but and we'll go that in detail. But basically, we're going to come up with a list of basically here's the highest score, here are some of the others below it that potentially could be selected, and then we're going to provide that information to the full board, so the full board can vote on who you want to select. And then, as Brian mentioned, there's some criteria that's going to be, I think if we go on those slides, it'll become a little bit easier to understand. I just don't want to go in that details when we have that on some of the slides coming up.
It may not be easier to understand initially, but eventually I think the process will make more sense.
Yeah, hopefully. Okay.
Let's go ahead and take a look at the next slides and we'll see what questions remain after that information. Yeah.
Okay.
Thank you.
Sure. Ruby, do you want to take this slide? Or,
I was gonna have Mercer since a lot of this information will be from you guys.
So this is maybe kind of going back, tracking a little bit, but really on the finalist interviews. And so, Sean, this is for you, Greg and Andy. The process. There's going to be a process. Basically, you'll take a look at the interviews or listen to the interviews. You will create some preliminary scores for yourself. But then we will have discussions. And so this is part of the overall 2-week process. So, for each day, we'll have the interviews, then we will have discussions just to make sure that if there's any questions that you have regarding some of the things that may have been brought up or any concerns or anything else, we can go through it and talk about it and make sure everyone's understanding on the same page. And then based on that, based on that debrief session and discussions, then you will go back and basically say, okay, these are going to be the scores I will have for the finalist interviews. And so there is going to be a little bit of a process. It's not just going to be your initial impression, but it's going to be basically, hey, we listen to it. This is what I thought. Okay, no, I'm going to change these scores a little bit because it's a little bit different compared to some of the others. Or, is that really best in class? Those sorts of questions that might impact your score. And so that would come out to your final score. And then we'll have that score for the interviews, combine them for all of the board members scoring, and then add that, take that weighting of the 25% of the finalists with the 75% for the scoring. And then adding those two together, we will come up with finalists, final rankings based on the points. And so once we get the final ranking, there's actually, if we move on to the next slide. Once we come up with the final rankings, basically, I talked about there at the top, we're going to basically determine who the potential ASPs are. And as Brian talked about earlier, generally the rule is the highest point total is potentially going to be the finalist or the one that you're going to vote for. However, there are going to be some exception criteria that's going to apply based on what things that we think are important to the board. We talked, I think, with Dawn and Siobhan about these a little bit in terms of the criteria. We will do an order of how we determine the ASPs based on pharmacy only, then statewide and coordinated care. But for the pharmacy only, again, you're going to have essentially all of the points. And so you have the top point score, and then potentially there could be an exception. And the one exception that we have is that if it's OPDP and it's within 1% of the highest scoring proposal. So basically this is essentially, hey, of the finalists, the board can select either the highest scoring or potentially OPDP, because OPDP is a Oregon program, right? And so you want to incent towards Oregon, and they're within 1% of the score of the top. So this is what we have it currently laid out. And then based on those, whether OPDP qualifies or whether it's just, potentially one ASP, then the board would then get the option to vote either for the high score or OPDP if OPDP qualifies under this exception criteria.
And just a note, this is the apparent successful proposer selection process. But when we select either the highest scoring pharmacy only proposer or OPDP, if they're within that 1% and the exception criteria apply, that pharmacy only proposer at that time is not an ASP. we're selecting them for purposes of marrying up or coupling with the medical only proposals that made it through the finalist interview process. So that way, after those combinations are completed, we will then have a single list of statewide proposals, mixed and matched, ranked by points. And then we'll have the same thing for all of the regional coordinated care proposals, except divided by region on that side.
And we will go, we have separate slides for all of this. So, so hopefully pharmacy is a little bit easier because we are talking about essentially the top finalist and then potentially OPTP. But that's the selection process for pharmacy. The next slide does talk about statewide. So statewide, there will be up to one, and we're giving potentially the option, just to give ourselves the most, I guess, leeway, up to one statewide proposer that would be selected. So in terms of the final, essentially creating this final ranking, it's going to be, whatever the total points for the statewide proposers, whether it's bid with, so based on their scores from the questionnaire plus the finalist interviews. There's also, as Brian was talking about, not everybody's going to bid medical and pharmacy combined. So we're going to come up with rankings based on those who bid medical and pharmacy, and that's going to be their total points. But if some plans bid pharmacy medical only, we need to combine their score with the pharmacy, and so that's going to be another score potentially, and whether they qualify or not, that's the question. But we will come up with the list of finalist points based on what they proposed in this case. The top, again, it's kind of similar to the pharmacy because we're selecting one. The top proposer is generally going to be the one that the PEB board is going to vote for, except if the second one falls under these proposed exception criteria, which is to the right. And so in order to be able to be considered to jump over the top score, you would have to be within 2.5% of the points. And one of the following things needs to be has to apply. So basically, it has to be that the advocacy solution is actually a better solution, and the board wants that better advocacy solution, or the disruption is less. So right now, these are the two exception criteria that allows a lower scoring proposer to jump ahead of the highest scoring proposer. So if the advocacy scores are better, or if the disruption is better in this case. So those are, so that's what we've proposed. One caveat there down below, if the advocacy criteria is selected in order to allow that lower scoring proposer to jump ahead of the higher scoring proposer, you have to have the advocacy solution as part of the contracting, because you're saying this is the reason we want to hire you is because of the advocacy, and therefore we're going to include it in the contract. But that is so that's the exception criteria. I think I will stop here and see if there's any questions. If you're understanding this or not, we can try to explain a little bit more. Are people
And just
getting
a note
this,
for
or is
those
this confusing?
for those board members who were around for the 2013 RFP, we had similar sort of selection processes set up where there was, one or more exception criteria based on the board's priorities.
So, the question is, are those essentially the board's priorities, either a better advocacy or less disruption? I mean, does that essentially meet things that you think would make sense to potentially jump up a lower scoring proposer in this case.
Yeah, I mean, that makes sense to me. Also, it needing to be within 2.5% of the other scores. Actually, when you're doing this kind of scoring, that's pretty narrow. So like it would have to be like real close. So yeah, that seems like a reasonable wiggle room at that point because it's like you're considering it very close. And so
And
at that point, there's a little bit of judgment of like, okay, they actually have a better whatever.
Mhm.
In this, yeah. So that makes
and
sense to
Sean,
me.
that's by design. The 2.5% was intentional in that if it were to be 25%, then we introduce some potential legal risks that people could come back and say, well, at 25%, it's all arbitrary, right? If this criteria ends up allow almost anyone to be selected. So the goal is really if all else is almost equal, these other factors would give the board some additional options to consider. The alternate would be we're going to select the highest scoring proposal regardless. And if that's not an option, then we look at just not actually awarding based on the RFP, which is, in my mind, probably a worse option to consider.
Yeah, and I mean, we did look at historical scores to kind of come up with that 2.5%. It is kind of narrow, and it is, I don't know if it's within the margin of error, right? But it's where it's close enough that maybe some discretion should be, leeway should be allowed. So that's the reason for it.
What I liked about
Okay.
this approach is
Mhm.
that it has the rigor of the scoring and very systematic comparison throughout the named priorities on behalf of the members and validated in all the ways that we've been able to validate. So there's that matrix. And at the end of the day, if the matrix, as closely as we have been able to design the formula to deliver a rank order, if it doesn't deliver that with clarity, then what are we going to use as priority values to help parse at the very end if you've got proposers who are functionally equivalent, potentially, as Emery mentioned, within the margin of error of any of the scoring. What are we going to use to make that distinction, and then we have to codify it. Where are we giving ourselves flexibility? What is the flexibility? How is it going to be applied to minimize any unjust sort of influence on the outcome? Like trying our best to make it happen formulaically. If not, here are our stated values, our stated priorities, and those can be used within this margin. That's what I liked about it.
Yeah, hopefully we've devised a process that makes sense and is rigorous, right? Logically rigorous, and meets the priorities of the PEB board. And the scores will come out what they may, but it is hopefully in alignment with what with the PEB's wants and needs, and then that and then you do have this little exception at the end, but hopefully it meets it makes sense in this case. Um, okay, so those two, I hate to say it, were probably a little bit more simple than the coordinated care version. So if we move on to the next slide, because we are talking about various regions, those different regions and the way healthcare and who might actually be different by these different regions. We will break out the scores by the different regions. Mercer will be calculating this and also working in coordination with staff, but creating the lists, the rankings and lists and potential scenarios, permutations in which the board could vote for ASPs. Again, the top score in each region should be potentially voted on by the board, but there are, again, more some exception criteria, and there are actually more exception criteria. We do have the caveats there that not all regions may have an ASP, just to give ourselves the leeway in case, as well as potential of multiple ASPs. So it's just basically saying, everything's up for grabs in this case. We did talk about number of plans each population could support, as well as competition. So that's going to help inform potentially the scenarios, the ranked lists, the scenarios actually that the PEB board could vote on. And we will try to, again, create multiple option permutations so that in that you could take a look and see what's possible, as well as, making sure that all of it meets the criteria that we're laying out. So on the right, just generally the proposed exception criteria. So we carried over the two from the statewide in terms of the advocacy and the disruption, but we also include carrier consolidation with other regions or a statewide PPO. So this does mean that potentially a lower scoring proposer, let's just say, for example, in the central region, but was going to be a winner in the Tri-County or in the I-5 corridor region, could be selected in this case. So that way you would have consolidation, you would have efficiency of scale, and you would have essentially like a connection, right? So that members aren't receiving disparate experiences, in this case. So that is another exception, that's criteria that's being included. And then for the advocacy, just a caveat that it must be included if you're going to use that. But this is, so those are going to be the exception criteria that we're proposing for the board to vote on. We are talking about potential multiple rankings, multiple ASPs. So that does, increase the number of scenarios and increase the complications in this. And let's move on to the next slide. Okay, so exception criteria. So it's, again, we are creating that 2.5% threshold. So if there's going to be potentially just one winner, that'd be two proposals. And the second proposal would be within 2.5%, or it could be multiple in that case. It could be the second and third are within 2.5%, or second, third, and fourth, or second, third, fourth, and fifth. So anyone that meets that 2.5% could be considered if they meet something in exception criteria. So again, the advocacy, it could be disruption, it could be proposed by the statewide plan, or it could be that they are potentially a winner in another region in this case. So, so those are the exception criteria that we're proposing. The thing is, though, you need to be able to justify, if you're second, you need to be able to justify being selected ahead of the highest scoring. But if you're third, you also need to be justified that you're able to be selected ahead of the second as well as the first. So in this case, you can't just jump up number 3 to number 1 if number 2 is better than number 3 in all ways. So that's a complication here. So in terms of the higher scoring under advocacy, if number 3 has better advocacy scoring than number 1, but it's not better than number 2, and the disruption doesn't apply, and then they can't be selected. But they could get selected if they are the same plan, essentially the same bidder as the ASP statewide, or if they are in another region in this case. So you do need to justify that each lower scoring proposal has a reason above every one of the other ones above it. It doesn't have to be the same criteria against each one. So you could have one that's higher scoring for advocacy, and another one against number 2, and higher for disruption against number 1, and that's okay. But you do have to justify that the lower scoring proposal has something in the exception criteria that justifies it above each of the ones above it. So this is going to create multiple permutations. We did come out with, we do have some documentation on describing how this might work, but it does allow some a little bit more leeway in terms of choosing plans that meets PEB's needs under advocacy, disruption, or consolidation of bidders. So I know that's a lot. I will pause here to see if there's any questions, concerns regarding this. Comments?
If I may, before we go there, I just wanted to check in with board members. I see that we're getting to 12:25. We are going to be calling for a vote. Is there anybody who needs to leave anytime in the next 15 or 20 minutes, maybe less? But is there anybody who needs to leave so that we need to expedite even more than that?
I'm not voting, but I'm leaving at 12:30.
Thank you. Anybody else? Sounds like we've got everybody for at least another 15, 20 minutes. We are running a little behind. I want to make sure that we don't need to either to rework it. Yeah. Go ahead, Emery. Thank you.
Yeah. Thanks, Don. Yeah. So I guess before we ask the board to vote on this, I guess just want to make sure we're addressing all of your concerns and that you feel that this is a process that makes sense in terms for selecting the winners.
Yeah, just for my clarity, just to state something, make sure I'm understanding it. So this is one of the reasons why we would be voting on or scoring and kind of making decisions, initial decisions on the statewide proposals first, because the outcome of the statewide decision could have an influence on the outcomes of the region.
The regional court. Yeah.
Because of some of this exception criteria, if all these things were met. Is that the idea?
Yes, that's the idea. And the pharmacy is first because potentially you want to know who might be the one paired with everybody else as well.
Right. Okay. Thanks.
So can you give me an example of what Sean was just talking about?
Okay. So this is not a reflection of who the winners are going to be. I'm just going to use, let's just say Providence as an example in this case, because this is the current situation we have. So let's just say Providence, as they won to the statewide before, they are the statewide proposer, and then they bid regionals as well. And let's just say, for sake of example, that Providence scored lower than MODA in the Salem area. So this would allow the PEB board to select Providence over MODA, even if they didn't have higher scoring advocacy or less disruption, because you want to consolidate in this case. And so the fact that purchasing power leverage, just working together, that gives you that ability.
Perfect. Thank you.
They would still have to be within the 2.5%. So it's not like the board is reaching down and trying to select a plan who didn't perform well. It's, again, just all else, being relatively equal, we're giving the board another decision option.
No, that makes sense. Thank you.
Okay. Any other questions or comments?
I have a question that's kind of a niggling doubt, but it seems like a proposer that is selected as an ASP in another region is it's a setup for sort of the too big to fail bigger entities to have a bit of an advantage. And I just want to be sure, if we're setting that up, that it's an advantage that we should be offering, and that it can be and will be leveraged on behalf of members. So for example, if someone has been approved in one region and is being considered for another region, that may make, let's say, the coastal areas that have fewer hospitals, that those coastal members could potentially come inland and have an expanded access to an expanded, deeper network that's outside of the region because they have a larger footprint in their payer. Just as an example, I just want, if we're gonna set up that consolidation as a lever toward an advantage, that we're doing that very thoughtfully.
It gives you the option to do that, yes. The board does not have to accept it, right? If you feel like it's not going to be that advantage or it gives too much, potentially maybe the bidder above the score higher is a better match. You don't have to apply the exception. You don't have to select it, but we're giving you the option in case that makes sense in this case. And we're creating scenarios that allows for this. Let's just say, um, Kaiser scores lower in this I-5 corridor versus what they did in Tri-County. It allows you the possibility of second Kaiser in that case. It's just, just giving you more options, more leeway.
Thank you. The other thing that concerns me about the regions is exactly what I just said. The depth of availability in some of those rural areas isn't the quaternary care that is available at OHSU, as an example, among our quaternary care centers here in the metro region, and wanting to ensure that the care that's available to people who live in those rural areas isn't limited to the providers who are located in those rural areas, but that they can get not just the breadth, but the depth of care that they need, the intensity of care that they need.
Yeah, and your members do travel for care, especially in the rural areas, right? And so just making sure they have access to it, that is another consideration. Yes, definitely.
Thank you. No more questions from me.
Okay. With that, actually, I think we do have a questions page on the next one, and I think we actually have all these answered. Thank you, Andy, for answering number two. Number one, again, just if you do have any questions, feel free to ask them. I think let's move to the next slide, which I don't know. I guess I can turn it back to you, Ruby. But this is where we're asking for action.
Thanks, Emery. And thank you for your assistance with the finalist information as well. Given that the board has been presented with all the information, we're just looking for a vote if we're able to go ahead and proceed with rolling out the RFP and making it public.
So I would like to make a motion that we authorize PEB staff and Mercer to finish developing and then release the RFP consistent with today's presentation, this discussion, that just as Ruby just read on this slide. So making a motion to do so.
This is Andy. I will second the motion.
Thank you for that. Greg Clauser, how do you vote?
I vote yes.
Thank you. Cheeky Flowers. Cheeky might be out today.
Yeah, Cheeky had to leave.
Yeah, thank you. Kimberly Hendricks is out. Sean Parkman.
I vote yes.
To authorize, thank you. Emily Wong.
I vote yes.
Thank you. 1, 2, 3, 4, 5. I think that's quorum. I think that's a vote, and I think that's authorization to proceed. Thank you very much for the presentation, the work, and for setting up a process ahead. This is a big bite. It's going to be a lot of work. You've set out a framework to maintain our values and hopefully set up our PEB employees for for a proposal process that is merited here. Thank you to our Mercer team and to our staff.
Thanks, Don. So the
thank you,
next
board
slide
members.
actually has a timeline. But you know, you can take a look at your own leisure, and we can move on to the next item. I think that should be it for our presentation.
Thank you. And the vote that we just did is for both the medical and the pharmaceutical, right?
Yes, it's for it's for medical, pharmaceutical, and essentially creating these 3 mini RFPs. So you have the pharmacy only to see who might be a potential PBM that's applied to the medical only, and then you have the statewide and coordinated care our portion of the RFP as well. Yes.
Thank you for that clarity. Okay. Given how our time is running today, I might just ask Sarah and Cindy to give us a couple of minutes overview, and then we can go into some detail on our comms plan at the next meeting. But please do take a couple of moments now and orient us.
Great, thanks, Dawn. My name is Sarah Berthume, and I am the Communication Coordinator for PEB and OEB. And this is our Open Enrollment Communication Strategy Preview. And so I'll just go through the highlights of it. If you go to the next slide. So for this year, since we do have a lot of changes, and there are a lot of changes in the nation overall, we're going to take a step back and try to talk a little bit more with members about open enrollment, why it's mandatory, what they can do to help manage their costs, and we're going to talk about why HEM is ending, describe plan changes. We know that Garner is a big topic that members are going to want to know more about. There is a change with Collective Health and Providence that we're going to be putting out extra communications for. So if you can go to the next slide, please. So last year was passive open enrollment and members didn't have to do much. This year is mandatory open enrollment. So we will really be pushing the message that members need to get in to pebenroll.com starting October 1st and make selections by October 31st, especially if the members want flexible spending accounts. Those are use it or lose it. You need to re-enroll for them every year. And then there are some other things that we can get into on our next call about what happens if you don't complete open enrollment. And then on the next 2 slides, we talk about the communications that we have planned for this year. And so we have some new communications. I'll hit on those. And then the next slide is communications that we do normally. So we'll spend a little more time on the first slide of the new ones so that we can just kind of quickly. So if you could go back 1 slide, please. Okay, so for the new communications for 2026, we are going to roll out a leader admin toolkit that leaders can use to get information ahead of time, kind of get ahead of the questions. It'll be a timeline, FAQs, talking points. We're also going to do a heads up email to members before open enrollment, significantly before. So then we are also offering a pre-open enrollment webinar this year so we can dig deeper into the landscape of healthcare and the changes with the medical plans and talk about why HEM is going away, what Garner is. We're also going to have customized resources explaining Garner for members who are with Providence Health or Moda Health. These will be FAQs, guides, and other materials to supplement what Garner provides. We are also going to be explaining the new partnership with Collective Health, and we'll have flyers and FAQs for those. And then we'll have some targeted emails for Providence Health and Moda Health members regarding Garner, and then lots of FSA education and planning tools to explain how Garner does work with those accounts. And So I know I'm going really fast, but I'm trying to touch on the things that we've heard so many calls for more communication in previous meetings, especially with the changes that we're having in Garner and new tools. And so we really wanted to show you that we're reaching out to all the different areas and touch points of communication to try to really get to members this year and explain what's going on and help them help us and help themselves keep costs down. I think if we go to the next slide, those were the typical communications. That's going to be our summary of changes. We'll have comparison charts, rates, benefit guides, sneak peek emails. These are all the normal things. We'll be updating our benefits tools, and we'll be having webinars, emails, so we can get into more of those next month if you want a deeper dive. But really would love to see if there's any questions or anything that, I know this was fast, but maybe that is on your mind that we should add to our strategy or that you didn't see here. So the next slide, I believe, is questions. And so yeah, final steps will finalize this communication strategy. So if you had any feedback, we have present the final communication plan in August. So it'd basically be this, but in a reduced speed.
Just a quick question, not for now, but for a future agenda item. Just given the number of communications needs we have this time, and then also trying to communicate about the fact that we're doing an RFP and like just trying to lay the groundwork for that. I wanted to revisit the general topic. We talked about this a few times over the years, but so my question is about how expectations are set or aren't by kind of executive leadership, DAS kind of level of like for agencies that the people in agencies who deal with benefits. And if the general strategy is that more or less they get an email from PEB and being like, hey, you should talk to your folks about this, that would be great. And that's kind of the end of it. Or if there's more of a sort of executive, like, hey, this is a thing, it's happening, and my expectation is from someone, I don't know who that would be, but my expectation is you're going to have some, discussions with your staff at your next all staff or whatever, I don't know. But I think what we've discovered over the years is that different agencies have very different approaches as to the level of communication that they do with their like new employees, ongoing employees, that sort of thing, to kind of amplify ours. And some agencies kind of leave it to us, like, look, that's PEB stuff. And you go to ask one of the HR people and they're just like, I don't know. And then there's other agencies that are really proactive. And so I'm just kind of checking in on that, not as I say, not right now, but for a future topic, like what does that look like as a general strategy? Do we have opportunities to talk to someone? I don't know who that is.
Yeah.
Yeah.
Yeah, actually, that's a great topic to bring up, Sean. We have addressed this actually for this year. We've created key messages. And so these are things that everyone at PEB agrees on, how the changes are going and, how programs will work. And then we're also making talking points and FAQs for a leader toolkit. So because we know that they do communicate different ways, they might pull together an email, they might make a poster. We have like these bullets that they can take from that, put into theirs and kind of structure it how they would like, but it is kind of the source of truth of how this program is working and what this change actually is and what it means to you. And then we do have a section in there about how can we work together to keep costs down and how just the landscape of healthcare in general requires us all to work together. And so we do kind of get into that consumer education, healthcare consumerism education in it. And so we're trying to structure it in a way that we know leaders are going to be getting these calls and these questions and kind of hard conversations leading farther back than just a copay changed this year. And so we are really trying to get that information out and have it in multiple different formats so that you can create your own message, but using consistent messaging, if that makes sense. And we do have some email templates we're going to be putting in there so that if you wanted to drop it into an email and send it out to your leaders, out to your members, or leaders could use it at their all staff if they wanted to. So we are also creating a script for the benefits team that's a little different format also. So in the way that the benefits team talks to members different than a leader talks to members. So we're really trying to get into all the different ways of communication and who is going to be asked these questions and then try to get the best way for them to answer it in that moment. So
And Sean,
Thank you.
I can address the executive level. DES has actually reached out to us in the past few months and really wants to partner along with the governor's office on, follow-up initiatives related to our PEB member wellness survey results. We have results at the agency level and how we can best take on some of these initiatives. Look at some different agency data as well as statewide data and come up with a strategic plan. So that's exciting to us. We've been trying to get them engaged for quite a while. So
That's very exciting. Love to hear more about that as you go. It's great.
Yep.
Yeah, I look forward to hearing more about that and how that can be leveraged to improve the quality of the information that PEB members are using when they're making decisions and developing their understanding of what's happening. So we'll look forward to hearing from you again next time, and potentially in the interim receiving some of this information so that we can think about it a little more and come up with any questions we may have in anticipation there. And thank you for working to develop that.
yeah, great. Thanks, everyone.
And with that, I'd like to move on to the last item on our agenda, which is that board members, if you would please note that there is one additional public comment in your packet for your review about FSA vendors beyond the concern about Providence that was addressed in this morning's conversation. Please do have a moment to review that. We will be responding to that. Ali, did you want to speak to that?
Nope, we already reached out and I think that was it. Yeah, to both of them.
Thank you. And with that, and with gratitude to all of you for your sustained attention, Greg Clauser, I see your hand is up.
Thank you very much. Yes, before we go, I would like to thank VSP, one of the largest vendors on the east side over here that does eye care for us, has decided as of July 1 that they would no longer